Okay, so we'll be covering anal canal carcinomas, gastrointestinal stromal tumors, small bowel tumors, and appendiceal carcinoma in our presentation. So, without wasting much time, I'll start with the anal canal carcinoma. First, we'll know what is the anatomy of the anal canal. Uh, as you know, surgical anatomy is the anal canal which runs from the anorectal ring, that is the proximal end is of the internal sphincter, to the anal verge. As you can see in this thing, I'll just put a laser pointer. See, this is the proximal limit of the anal canal. This is the anal sphincter, levator ani muscle, and puborectalis. This is puborectalis muscle. So proximal limit where the upper limit of the internal anal sphincter finishes, and the distal limit is the anal verge where anal canal finishes and the skin starts. Okay, so this is the surgical anatomy of the anal canal. Its length is about 4.4 centimeter in males and slightly less in females, to about 4 centimeters. So it has three zones. One is the upper zone is the in the rectum, this is columnar epithelium lined zone. Next is the transitional zone, and it lies between the colorectal mucosa and the squamous epithelium of the anal canal. So this contains transition zone. It begins about 5 millimeter above the dentate line. This is the dentate line at the lower limit of the anal columns of Morgagni. Okay. So these are the redundant fold. These columns are the redundant fold, and they contain anal crypts. In between the folds are the anal crypts, and they contain between 3 to 12 in number anal glands. They are the anal gland which are present between the fold, and they are one of the reason which we'll study later for development of adenocarcinoma in the anal canal. So in the anatomy, you'll know the transition zone and anoderm, anal verge, dentate line. These are all the important things to know about in the anal canal. Next, we'll read is the sphincter mechanism. Okay. So internal anal sphincter. It's a abridgment of circular smooth muscle layer of the rectum. The circular smooth muscle layer, it condenses to form the internal anal sphincter. Typically, it is 2 to 3 millimeter thick and about 35 in length. It is similar to the length of the anal canal, and it is responsible for about 50 to 85% of the involuntary resting tone. And external anal sphincter is described usually as a external anal sphincter is classically described as a tube of skeletal muscle that extend upward to meet the puborectalis muscle and the levator ani muscle. So in this, you can see the external anal sphincter. It moves up, it meets the puborectalis muscle, and it has three parts: deep part, superficial, and the subcutaneous part of external anal sphincter. So in the three components, external of anal, most proximal is the deep component. This it condenses with the puborectalis muscle. Superficial component, it is the intermediate portion of the anal sphincter, and it is posteriorly attached with the coccyx bone. And subcutaneous is the most distal. The external anal sphincter, it is also contributing to the involuntary resting tone in about 25% of the cases. It is in contrast to the other skeletal muscle. It has an internal resting tone. The tone is via the reflex arc. So the nerve supply of anal sphincter is internal anal sphincter is supplied from the sympathetic innervation from L5, and parasympathetic innervation is from the nervi arteriosus. The nervy laryngitis is the parasympathetic preganglionic fiber from S2, S3, S4. Okay. The external anal sphincter, it receives bilateral innervation via S2 and S3, and this is the inferior rectal branch of pudendal nerve, and via the perineal branch from the S4. Coming on to the lymphatic drainage, the lymphatic regional lymph nodes for anal canal are mesorectal lymph nodes, external this is inguinal, superficial and deep inguinal lymph node, external iliac, internal iliac, and the superior rectal lymph nodes. Okay. So the tumors below the dentate line, suppose this is the dentate line, below the dentate lines, they will drain into the superficial and deep inguinal lymph nodes, and some into the external iliac lymph nodes. If they are at or proximal to the dentate line, they will drain into the mesorectal lymph nodes and to the internal iliac. If they are more proximal, they'll go through the superior rectal into the inferior mesenteric system. So, and next is the histological feature. The mucosal lining of the anal canal is predominantly lined by the squamous epithelium. As we have seen in the rectum, it is columnar epithelium, and in the anal canal, predominantly squamous. There is a transition zone. Superior most aspect of the anal canal, in the transition zone, it is lined by all the, because there is a transition, it is lined by rectal, urothelial, and squamous histological characteristics. And most inferior part of the anal canal, it is the mucosa lined with modified squamous epithelium, which transition to the epidermis lined anal margin. So I'll ask one question here. Okay. There was one question from Raksha. Recently asked Jitmar question. Least helpful in anal continence is levator ani, internal sphincter, external sphincter, and rectal sensation. So in this case, the answer should be levator ani muscle, I guess. So I'll confirm this answer, and then we can have a we can have a discussion on this thing. Most likely answer should be levator ani muscle in this case, because rectal sensation will lead to contraction and anal continence. So tell me, what is the question is, internal sphincter of the rectum is formed by levator ani muscle, puborectalis, longitudinal muscle fiber condensation, or circular muscle fiber condensation. Please answer your in the comment box. Please put your options. So two persons have answered C and one has answered D. Answer is D, circular muscle fiber condensation. As we have told in this slide, the internal sphincter is the bridgement or condensation of circular smooth muscle layer of the rectum. So it is not the longitudinal muscle, it's a circular muscle fiber condensation which forms the internal sphincter. So coming on to the anal canal carcinomas, anal canal tumors, they are defined as tumors which develop from the mucosa that cannot be entirely seen when the buttocks are gently pressed. Okay. So these are tumors like in A, like A, B, and C. C tumor is not, upper limit will not be visible when the buttocks are gently pressed. These form the anal canal tumors. And perianal tumors, they arise from the skin distal to or at the squamous mucocutaneous junction. They are near the anal canal and they can be visualized completely when the buttocks are gently pressed. So if it is pressed, the upper limit can be seen completely, and they are usually within the 5 centimeter of the anal verge. And this one E type, this tumor is a skin tumor. This is beyond 5 centimeter of the anal verge. So it is considered as a skin tumor, not an perianal tumor. So various histologies in the anal canal carcinomas. Most common is the squamous cell carcinoma. It used to be defined into various subtypes, but they are now obsolete. They are not used in the WHO classification. They included cloacogenic, transitional cell, squamous cell carcinoma, keratinizing type, basaloid type. They are not used nowadays. And because all the keratinizing, non-keratinizing type of squamous cell carcinoma, they all have a natural history which is similar, and the prognosis is also same. And there is no difference in the treatment also. So most squamous cell carcinomas are moderately to poorly differentiated, and they display coilocytic changes which are consistent with HPV infection. What are the coilocytic changes? These are the coilocytes. They'll have a dense nuclei which is hyperchromatic, and it will have a perinuclear halo, and nuclei are also larger than the normal cells. They are hyperchromatic large nuclei with a perinuclear halo. They are typical coilocytes. Other less common histologies are adenocarcinoma, basal cell carcinoma, verrucous, mucinous carcinoma, high-grade neuroendocrine carcinomas, and melanomas. They are very less common. Majority, 90% of the times, the histology is squamous cell carcinoma. So adenocarcinoma is rare. It can arise from three varieties. It can be categorized into three categories, like those which extend from the above the dentate line. They are practically rectal cancers. They are above the dentate line, and those that originate from the underlying anorectal glands, or if there is a long-standing fistulous disease, the tumor adenocarcinoma can arise from those uh, areas, and those which primarily arise from the anal mucosa or perianal skin. So these are the categories from where adenocarcinoma can arise. And for perianal cancers, if they can be resected completely without damaging the internal sphincter, the local resection is the preferred modality of treatment for those adenocarcinoma. And those which involve the adenocarcinoma and involve the internal sphincter, and they are lining the anal canal, for those, treatment is similar in lines with the rectal cancer. After neoadjuvant chemoradiotherapy, APR is done. For very small tumor, that APR can be done for without giving neoadjuvant chemoradiation. Basal cell carcinomas, they are account for 0.1% of all basal cell carcinoma and less than 1% of all anal canal malignancy. They do not have a well-defined precursor, and they usually arise in the perianal skin, and they are associated with very low recurrence, and wide local excision with negative margin remains the standard of care, especially for the small region. And if there are large lesions, you can go with the extensive radical surgery with APR, or those who are not willing for this surgery or with very extensive disease, radiation can be used as a modality for treatment. Um, Coming on to melanomas, anal canal melanoma, they form about 1% of all malignant melanoma and 0.5% of the anorectal area melanomas. anorectal area carcinomas, and they are usually pigmented lesions, but sometimes they are amelanotic in about one third of the cases. And at presentation, most of them have metastasis to the mesorectal, like 40 to 60% of the cases will have mesorectal lymph node mets, and inguinal lymphadenopathy in found in about 20%. And distant spread also occurs to bone, lung, and liver. Surgery is the mainstay of treatment. Surgery can be local excision with or without RT, and it can be abdominoperineal resection. Local resection, if it is possible, then it is preferred modality. Initially, it used to be the modality of treatment used to be abdominoperineal resection for all malignant melanoma, but the recent studies have found that local excision has also similar results, similar survival, similar disease-free and local recurrence rate are similar to APR. So it is not recommended anymore if it can be done with the local resection only. So 5-year survival rate for anorectal melanoma is very poor. It is about 6%, and median survival is only 15 to 18 months because of the very aggressive nature and early distant spread which occurs in this disease. Epidemiology of anal canal cancers is it is the least prevalent among all GI cancers, and 1 to 2% of all large bowel malignancy is constituted by anal cancers, and median age is about 61 years, and they are slightly more common in females, especially the Caucasian females, and less incidence among the Asian, both males and females. And its incidence has risen over the last 3 decades because of increase in the infection with HIV and HPV virus, and also because of the introduction of HART. This is highly active antiretroviral therapy, ART, for HIV, which has led to increase in life expectancy of HIV patient, and also increasing the risk of malignancy which develops at a later date. So HPV DNA is involved in 90% of the anal cancers, and the most common variants strains of HPV are HPV 16 and 18. HPV 16 is involved in about 70% of the anal canal cancer, which is more than the cervical cancer, and HPV 18 it is involved only in 10% of the anal canal HPV related cancers, and it is the incidence is less than that of cervical cancer, and its incidence of HPV infection is higher in homosexual men and those and women who receive anal receptive intercourse. Other etiological factors are HIV infection. It, HIV infected people have high propensity for developing anal canal cancer, and increases with the increasing age, with 67% developing cancer after the age of 55 years. Smoking is also a risk factor with the relative risk of about 3.8, and immunosuppression, whether it can be because of HIV or due to solid organ transplant, it increases the risk of anal canal cancer. In solid organ transplant recipient, it is 6 times the normal population. So, like cervical cancer, there are pre-malignant precursor for anal canal cancers also. It can be graded like mild dysplasia, moderate, severe dysplasia, or according to the AIN classification, anal intraepithelial neoplasia can be grade 1, grade 2, or grade 3, or it can be categorized as low grade SIL or high grade squamous intraepithelial lesion. And after high grade, there is microinvasive carcinoma which develops. So prevalence of anal intraepithelial neoplasia is high among homosexual men, even if they are HIV negative, it is high among homosexual men. It is more than 36% of the population. And in HIV positive homosexual, it is almost universal. Okay, so and usually in grade 3 AIN, it progresses to uh, invasive adenocarcinoma in about 5% of the cases, and increased rate in immunocompromised patients. But regression from grade 3 AIN to lesser grades is very uncommon or less known actually. In one of the article study by Tong et al, they have found about 23% of the patient who are diagnosed with high grade dysplasia, they regress to normal grade. And HPV 16E specific CD4 T cell response, if it is present in the uh, cells, tumor, and it is associated with the spontaneous regression. So, high grade dysplasia, they progress to invasive carcinoma in about 5% of the cases, and regression, they can, it is unknown, but in one study they have found about 23% are regressing to lower grades. P16 is one of the marker which is helpful in detecting HPV related anal. So other pre-malignant conditions associated with anal cancer are verrucous carcinoma. It is also known as giant condyloma or Buschke-Lowenstein tumor. They have very large, often cauliflower-like appearance, and they are usually locally destructive and are HPV related. The strains associated with this one is HPV6 and HPV11. They are usually low grade, slow growing, and they are associated with high rates of local recurrence. And malignant transformation is also seen in up to 50% of the cases. And in some way, some forms, it is considered as a malignant itself. Next is the Bowen disease. It is a slow growing intraepidermal squamous cell carcinoma. It mimics perianal dermatitis. And Paget disease, it is also similar to the like in breast, it has an eczematous appearance. Okay, you can see the eczema around the anal verge, and they are usually positive for PAS, mucicarmin, alcin blue, and cytokeratin 7. There is progression from perianal Paget disease to invasive disease is only in about 5% of the cases the progression is seen. But about 50% of the Paget disease, they harbor some kind of underlying adenocarcinoma, most likely in the tumor, colorectal region, and some in tubo-ovarian also, they'll have invasive adenocarcinoma. And wide local excision is the treatment of choice for Paget disease, and recurrence is seen in as high as 61% of the cases. So this brings to next question. What is the most common surgical complication of condyloma acuminata? Please put your answers in the comment box. So is it infection, recurrence, hemorrhage, or malignant change? Yes, the answer is recurrence. It is the most common surgical complication because the recurrence occur in about 70 to 80%, and malignant change in about 50% of the cases. As otherwise, also infection also looks like an possible option, but this is not the answer in this case. Uh, so answer is recurrence. Screening for anal intraepithelial neoplasias is like in cervical cancer. Anal pap smear can be taken, and if there is abnormal cytology, like I mentioned in the anal intraepithelial neoplasia, if it is found that it's grade 1, 2, 3 or anything, then high resolution anoscopy is done. High resolution anoscopy is the with directed biopsy is the gold standard for detection of high grade squamous intraepithelial lesions. And routine screening is not recommended in anal cancers. Although because of the low incidence rate of anal cancer, routine screening is not a cost effective measure. Because there are not much study, there is lack of evidence among routine screening. So what are the treatment for high grade anal intraepithelial lesions are? Ablation with electrocautery, topical trichloroacetic acid, topical 5-FU, imiquimod. These are and this can be applicable chemotherapeutic agent or with the electrocautery. Estimated rates of control are about 60 to 80% in high grade lesions. So, how to prevent these lesions? Although we are not doing regular screening, but prevention can be done with the help of vaccination, as in cervix. So, we have uh, bivalent vaccine, that is Cervarix, and quadrivalent vaccine, that is Gardasil, and there is also 9-valent vaccination available. Gardasil is quadrivalent HPV infection. It demonstrated efficacy against HPV 6, 11, 16 and 18. 16, 18 is the most common type in the squamous cell carcinomas, and HPV 6 and 11 for the benign lesion or pre-malignant lesions. So it protects against the genital warts and also against the cancers of the anus, vagina, vulva. And 9-valent vaccine, it has been found to be similar in generating immune response to 6, 11, 16 and 18. So inclusion of other strains has not decreased the immune response among the most common strains, and the calculated efficacy is about 96.7% for prevention of high grade cervical, vulvar, vaginal disease. And it is recommended, like in cervix, for girls of age 11 to 12 years, and in this also boys for 11 and 12 years, and girls between age of 13 to 26 years who have not been vaccinated previously. And MSM is men having sex with men. Homosexual men, it is up to 26 years who has not been previously vaccination vaccinated. This is called catch-up vaccination. Initially recommended only for 11 to 12 years, but later on extended the vaccination to up to 26 years. So in a study, they have found that there is 50% decrease in the risk of developing high-grade dysplasia in HIV positive homosexual men. And Deshmukh et al. They constructed a Markov model in which they have found that the vaccination reduced the lifetime risk of developing anal cancer by about 60%, and it is highly cost effective with decreased lifetime cost and increased quality adjusted life expectancy. So uh, screening was not cost effective, but preventing it with a vaccination is cost effective. So these are the recommendation, and it should be given to all the girls and boys between age 11 to 12 year, and catch up vaccination. So clinical presentation of anal canal cancer, it most common is the bleeding from the anus, but some can present with pain, itching, anal discharge, feeling of tenesmus, and a feeling of fullness or lump in the anal canal. Most common features of the advanced disease are incontinence. Involvement of the anal sphincter leads to incontinence, passage of gas or stool from the vagina. So this is development of rectovaginal fistula and other changes in the bowel habits. They are also features of advanced disease. Inguinal lymph nodes are present in some, but in those which have enlarged inguinal lymph node, among them 50% will have positive nodes for malignancy, and about 20% will be asymptomatic for the disease. Staging evaluation will include digital rectal examination, palpation of inguinal lymph node, anoscopy, and biopsy and FNAC of suspicious nodes. And again, CT chest, abdomen, and pelvic MRI. A PET CT should be considered if it is available. It is in contrast to the rectal and colonic carcinoma, where PET scan was not recommended. But in anal canal cancer, PET scan should be done if it is available. Next is HIV testing, gynecological examination for women, and screening for cervical cancer and fertility preservation counseling. So some people have tried sentinel lymph node biopsy, and they have found success in identifying sentinel lymph node in about 86% of the cases, because there can be some distant mets like in mesorectal or internal iliac region. So identification rate for sentinel lymph node is only about 86%. This is in contrast to the breast carcinoma, where about 98-99% sentinel lymph node identification rate with the help of blue dye and radio tracer isotope. So exact role for sentinel lymph node biopsy in anal canal cancer is still undetermined. So PET scan is an important investigation for anal canal carcinoma. It upstages the disease in about 14 to 20% and changes the management treatment course in about 17 to 34% of the patient. It is useful like in avoidance of unnecessary biopsy. It will help in distinguishing between the recurrence and the other change radiotherapy like associated changes or other infection, and in avoidance of unnecessary biopsy and surgery. And it also has a prognostic values, like if there is complete metabolic response, it is associated with better progression free and overall survival compared if there is low metabolic response post treatment. So coming on to the staging of anal canal cancers, TIS is in situ carcinoma, high grade intraepithelial lesions. So all the intraepithelial lesions and even the our pre-malignant lesion like Bowman disease come into this thing. T1 tumors are 2 centimeter or less. T2 is more than 2 centimeter, not less than 5 centimeter. T3 is more than 5 centimeter, and T4 involves any of the adjacent structures like vagina, urethra, or bladder. Nodal metastasis, they are N1 is inguinal mesorectal, N1A is inguinal lymph node, mesorectal lymph node, and internal iliac lymph node. And N1B is external iliac lymph node, and N1C is any involvement of the both of these nodes. M1 distant metastasis. So T1 will be stage 1 is T1, and stage 2 T2 T3 without nodal involvement. T3 stage 3 will be any nodal involvement or T4 tumors, and stage 4 will be metastatic disease. So in this, they in the AJCC 8th edition, major change is N2, N3 categories were removed, and they have introduced new category of N1A, N1B, N1C, and rest they have just defined the landmarks of anal, perianal tumors, etc. So what are the prognostic factors associated? The most important are T staging, and second is N staging, and like tumors more than 5 centimeter, T3, N positive nodes, and male sex, they are associated with poorer prognosis. And what are the molecular prognostic factor? They are P53 gene overexpression. It is associated with the worse locoregional control and disease-free survival. It is overexpressed in about 34 to 100% of the patients. So thus there is uh, poorer prognosis of anal canal cancer. If there is P50, P21 gene lack of expression, then it is associated with poor prognosis and worse overall survival, increase in local failure rate. K6, Ki67, if it is more, as we know, they are highly proliferative type of tumor, then it is associated with negative prognosis. And other factors like nuclear factor kappa B, sonic hedgehog, and GLI1, they are positively associated with disease-free survival. And high pre-treatment neutrophil lymphocyte ratio in blood sample is associated with increased recurrence risk, worst overall survival. And P16 expression in tumor tissue is also associated with high risk of recurrence. These are HPV related tumors. There is high risk of recurrence, but again the prognosis is good because of the better chemosensitivity of HPV related tumors. Coming on to treatment, surgery was initially offered in the historical times. APR was done, radical surgeries were done, but they were associated with high recurrence rates and with low disease-free survival and low overall survival. So nowadays, surgery is only limited. Initial surgery is only limited for perianal cancers, and those two which are very small, well differentiated superficial lesions, they are involving the perianal skin and not involving the anal sphincter, and they are also without nodal involvement. So T1N0 well differentiated tumor or selected T2, they are taken for local excision, and if adequate margin is obtained, then observation. If you do not obtain adequate margins, then re-excision, or if it is not possible, then chemo RT. So this brings to the main treatment for anal cancer. It is the definitive chemoradiotherapy. So coming on from historical radical surgery to chemoradiation is a big step which was pioneered by Negro et al. They incorporated concurrent pelvic RT with chemotherapy using 5-fluorouracil and mitomycin C as the agent, and they have found high rates of pathological complete response and survival. So these are the three landmark trials which have studied radiation with in comparison to chemoradiation using 5-FU and mitomycin C. And first study is UK Act 1 trial. They have found lower locoregional failure rates, higher relapse-free survival, higher colostomy-free survival with addition of chemotherapy in radiation with 5-FU and mitomycin C, and overall survival was also better with chemoradiation, but it was not significant. It was at the expense of increased toxicity, increased skin toxicity, and increased GI toxicity. So ERTC also compared radiation with chemoradiation, and they again found similar results with 18% improvement in the locoregional failure rate, 32% improvement in colostomy-free survival, and 7% improvement in overall survival, but non-significant with higher toxicity with the chemotherapy arm. So next, the RTOG trial, they considered whether we can omit only MMC and not 5-FU. So they compared 5-FU with radiation, chemoradiation with 5-FU, or chemoradiation with 5-FU and mitomycin C. In this, they also again found higher locoregional failure rate with only 5-FU and better relapse-free survival, better colostomy-free survival, and overall survival also was better when mitomycin C was added to radiation therapy. And although it was associated with higher toxicity. So the treatment regimen of choice is radiation along with addition of 5-FU and mitomycin C. So in further studies, they tried to replace mitomycin C with cisplatin. So there are three trials for this also. RTOG trial, they compared EBRT with fluorouracil and mitomycin to in comparison to 5-FU cisplatin neoadjuvant, followed by EBRT along with 5-FU and cisplatin. Okay, so they changed the mitomycin component and given neoadjuvant chemotherapy also in the other group. And in the result, they did not find any significant difference in 5-year disease-free survival, overall survival, and locoregional survival. And colostomy rates were lesser in the mitomycin groups and then in the cisplatin group. So initial report also showed that colostomy rates are lesser, but there was no difference in the survival. But an update to this trial has shown that The disease-free survival, overall survival, and borderline colostomy-free survival are better in the mitomycin-containing arm. So the long-term data has shown that mitomycin is better than cisplatin if to be added with chemoradiation. So second trial in this series was Act 2 trial. They compared EBRT with 5-FU cisplatin or with 5-FU mitomycin, and they given adjuvant chemotherapy also after finishing chemoradiation therapy. And they at 6 months they have found no difference in the clinical response rate in the two arms, mitomycin and cisplatin arm, and 3-year colostomy free survival was also similar between the two groups, and there was no difference on addition of maintenance chemotherapy after finishing radiation. So in this group they have found that cisplatin based chemoradiation and mitomycin based chemoradiation are similar in all aspects, and there was no use of adding adjuvant maintenance chemotherapy. So, but in the end, the authors concluded that MMC should be used, that mitomycin should be used in contrast to cisplatin because of uh, better handling with the mitomycin C. There is no increased sepsis with mitomycin C. It is easy to deliver than cisplatin. It is associated with low cost and fewer cycles were required, and lower use of non-chemotherapeutic agents with mitomycin C and less neuropathy. So mitomycin C is still the drug of choice to be used with EBRT. And post hoc analysis also it has shown that there are higher complete response with mitomycin containing arm than cisplatin. And as we know that those patients who achieve complete response, they have better survival, better 5-year survival, and those who did not achieve complete response at 26 weeks. So another thing we have found is there are more complete response at 26 weeks than it at the 3 or 4 weeks after chemoradiation. So this will also affect our treatment protocols. Next trial is Accord 3 trial. They have used, it is a double crossover trial. Initially they given 5-FU cisplatin neoadjuvant chemotherapy in one group and continued with the EBRT with 5-FU cisplatin in the other group. And following completion of EBRT with the chemotherapy, they have given a boost of radiation of 15 gray or higher boost with 20 to 25 gray in both the groups. So results were not different in no difference in 5-year colostomy free survival rate, no difference in terms of disease specific survival, overall survival. And they have also found that induction chemotherapy also doesn't help. And in the most intensified regimen, like in the 5-FU cisplatin neoadjuvant chemotherapy with followed by chemoradiation followed by high dose boost, they found slightly better local control, and it was hypothesis generating that it can be explored further. But overall conclusion was that neoadjuvant chemotherapy doesn't help, and there was less no use of giving boost also. So according to coming on to the conclusion from 3 trial, mitomycin C is better than cisplatin, and there is no use of giving neoadjuvant or adjuvant chemotherapy, and no use of giving boost also. So follow up, usually first follow up is done at 8 to 12 weeks. It is 8 to 12 weeks, 3 months after the completion of chemoradiation. We do a visual inspection, digital rectal examination, anoscopy, and palpation of inguinal lymph node. And next evaluation is at 3 months. And after that, every 3 to 6 months for first 2 years, and then 6 to 12 months until 5 years of age. So if the disease is persisting beyond the following 3 months following the treatment, it is labeled as a residual disease. So chronically persisting or recurrent tumors, they should be again biopsied for presence of tumor. So after chemoradiation, some people will achieve complete remission. So follow-up is done every 3 to 6 monthly with DRE, inguinal lymph node palpation, anoscopy, chest and abdominal CT every yearly for 3 years. Okay. So those who are having persistent disease at 3 months, they should be again reevaluated and at 4 weeks. So if there is regression of symptoms, then they should be evaluated or continuously observed at 3 month interval, or if there is progression of disease, progression we'll see in the next slide. If there is progression, or if there is local recurrence or inguinal lymph node, if there is local recurrence is found, then abdominoperineal resection is done. And if inguinal lymph node recurrence is found after complete remission, then groin dissection only to be done. And if radiation was not given to the groins previously, then uh, CTRT to the groin is also given. So what to be done in case of progressive disease? If there is progressive disease, biopsy to be done and restaging with the help of PET scan to be done. And if it is a locally recurrent tumor, then APR for local, and groin dissection if there are inguinal lymph node positive. And if it is a metastatic disease, then palliative chemotherapy to be given. The surveillance protocol I've already told: DRE, anal, inguinal lymph node palpation, and anoscopy every 3 to 6 monthly, then CT annually with pelvic MRI. In case of persistent or recurrent disease, salvage surgery with abdominoperineal resection is the recommendation of choice. And it is the only curative option, and a negative margin should be obtained. If it is invading into the adjacent organ, it warrants en bloc resection. If it is invading into the vagina, uterus, anywhere, then exentration should be done. If there are positive lymph node, groin dissection to be done. Some people have used intraoperative radiation therapy or brachytherapy for close or involved margins at resection, but others have not found its use. So some have found improvement in control rate, but recent studies have not found its use in decreasing the local recurrence. So low dose re-radiation therapy with concurrent chemotherapy can also be used in selected patients. And after achieving complete resection, 5-year survival is between 30 to 70%, and disease-free survival between 30 to 40%. What are the predictors of poor outcome following salvage surgery? Is number one and most important is positive margins. If positive margins are not achieved, if the negative margins are not achieved, then it is high likely of uh, poor overall survival and local recurrence. Inguinal lymph node involvement is a poor prognostic factor. Tumor size more than 5 centimeter, adjacent organ involvement, male gender, and presence of comorbidities. They are all associated with poor overall survival. Some people have found persistent disease to be associated with poorer survival than recurrent disease, because like hypothesis is that persistent disease will contain tumor cells, those cells which are resistant to the treatment. Like with chemotherapy and radiation therapy, they are resistant to that treatment, so they have high chances of again recurrence even with the salvage surgery, and poor overall survival. Korea et al., they have devised a scoring system for predicting the post-op survival based on three factors: lymph node involvement, involved surgical margin, perineural or lymphovascular invasion. And they have found that if none of these factors is present, then it is associated. the 5-year survival is about 55%. So what is the morbidity associated with salvage resection? Because it is an area where already chemoradiation was given. So the local morbidity is very high. It is present in about 72% of the patient undergoing surgery. And the most common is delayed perineal wound healing. Others are presence of pelvic abscesses, development of pelvic abscesses, perineal wound hernia, urinary retention, as well as development of impotence. That is, erectile dysfunction can occur because of nerve injury. So, closure of the wound, if it is done by primary intention, that is, the wound edges are brought closer and sutured, it will give to it will give suboptimal result and definitely lead to perineal wound healing problems and fistula. The most common flaps used for covering the defect are omental pedicle flap, gracilis muscle flap, and VRAM flap. VRAM is vertical rectus abdominis myocutaneous flap. It is the most commonly used flap and it gives the best results among all the three. So VRAM flap is the preferred flap among the three for covering the defect. So we go on to a question. A 45-year-old HIV positive man. He presents with newly diagnosed stage 2 squamous cell carcinoma of the anus. He is not compliant with his antiretroviral medication. His last CD4 count was less than 200. He is asymptomatic and if it was found on incidentally on digital rectal examination. He has no history of opportunistic infection. What is the recommended treatment? So whether to is concurrent 5-FU mitomycin radiation therapy without dose reduction and weekly monitoring for blood count and close monitoring of treatment related toxicity. Next option is omitting mitomycin. Third option is a concurrent CTRT with 25% decrease in mitomycin. Fourth is radiation only. What are your answers? So HIV positive patient with less than 200 CD4 count, what should be the treatment option for this thing? Anyone? You cannot put question in the answer. C followed by a question mark. So answer is A. In this patient, usual recommendation which we'll see in the later slide that if patient is fit and they should be given complete chemoradiation and monitoring of blood counts and close monitoring of treatment related toxicity to be done, and the CD4 count is not a matter for treatment decision of the treatment. The answer is A. So we'll discuss something about patient with living with HIV. People living with HIV with anal canal cancer. Most studies do not include HIV patient, positive patient, and some people have compared taking HIV patient, positive patient and found comparable results to the chemoradiation. And treatment on basing on CD4 count. Hoffman et al. They found low toxicity to chemoradiation in patient with CD4 count more than 200. But other trials, including one CHAMP trial, they have found no difference in the median survival overall and also based on CD4 counts. and they are also not found increased toxicity in patient with lower CD4 counts. So introduction of highly active antiretroviral therapy has improved the CD4 count and also the survival rates with HIV positive patients. And the antiretroviral therapy, it should be given prior to chemoradiation, then starting after the chemoradiation. So it will give better results and lower toxicity and improves the immunity of the patient because it improves CD4 count. And clinical outcomes have shown that HIV treated with heart and chemoradiation has similar results to patients who are HIV negative. But in one study, they have found that uh, significantly poor outcomes for HIV positive patient compared to HIV negative. It may be because of like HIV infected patient are more likely to be younger and male patient, and we know that the young patient and males have poor prognostic. They are both poor prognostic factors. So Devita mentions that it is sorry, it is not necessary to alter the standard management recommendation in HIV infected patients, especially those with CD4 count less than 200, and they should be monitored for increased risk of toxicity when treated with chemoradiation. And chemotherapy omission is also not recommended, and factors which are important in formulating our treatment plan are pre and post treatment CD4 count, compliance to heart, and performance data. In our question, he was a young man without any comorbidities, and it was found anal canal cancer was found incidentally, and his performance status was also good. So, no need of omitting chemotherapy in the treatment. So, if patient develops metastatic disease after, or if it is uh, at presentation or later on if develop metastatic disease, the only options are palliative chemotherapy. Various drugs used are 5-fluorouracil cisplatin, carboplatin paclitaxel, Folfox, Folsis, and modified DIS. So, in the second line, if there is progression on these agents, then they can be considered with nivolumab or pembrolizumab in some patients. So, metastatic disease develop in about 10 to 20% of patients with anal carcinoma, and in the most common site of metastasis are liver, lung, and extrapelvic lymph nodes. So another question is 49-year-old woman present with rectal bleeding from 2 months. She does not have any pain, diarrhea, constipation, weight loss. Colonoscopy revealed a 2 centimeters mass low line 1 centimeter from anal verge. Transrectal ultrasound, no lymph nodes, and biopsy shows basiloid squamous cell carcinoma. What is the best treatment option? It's a simple one. What is the treatment option for anal squamous cell carcinoma? APR, short course RT followed by APR, neoadjuvant chemoradiation with 5-FU followed by APR, or chemoradiation alone with 5-FU and mitomycin. Yes, the answer is D only. The only thing which we had to consider is to see the biopsy. It is basiloid squamous cell carcinoma. We should not miss this thing from the question. If it had been in adenocarcinoma, so our treatment would have changed. We could have given neoadjuvant chemoradiation with 5-FU. So it is important to read the question properly. So this brings us to the end of anal canal carcinomas. So in a gist, treatment is most common is squamous cell carcinoma, and the most common the treatment option is chemoradiation with 5-FU and mitomycin. There is less role of cisplatin or radiation alone, and surgery to be used only in recurrent or residual disease, and it is best done with APR. So if you have any question regarding anal canal carcinoma, you can message me. Next, we'll be starting with gastrointestinal stromal tumors. It is the most common mesenchymal neoplasm of the gastrointestinal tract, and they arise from the interstitial cells of Kajal. These cells are the mediators of neurotransmission from nerve to the smooth muscle. They are mediator of neurotransmission, and they are also labeled as the pacemaker of gastrointestinal motility. So important thing is development from interstitial cell of Kajal, and most common mesenchymal neoplasm of the gastrointestinal tract. The median age is usually 60 to 65 years, but it can occur at any age. Those occurring in children and young adults, they are more likely to be wild type for KIT and PDGFRA mutation, that we'll understand in next slide. They are not associated with mutation, and they are more likely to be associated with some syndrome or syn- syndromic gist. Males are more likely to develop gist than females, but in young females, SDH deficient cysts are more common. They are syndromic cysts. So, cysts associated with some syndromes, they are more likely to be wild type for KIT and PDGF. They are more associated with SDH deficiency and more likely to occur in children and young females. The vast majority are sporadic, and there is no likely risk factor for this, but in some cases prior radiation has been found to be a risk factor for GIST, and various predisposing condition for SDH, succinate dehydrogenase deficient GIST, are associated with the syndromes of Carney triad. They are marked by GIST, pulmonary chondroma, and extraadrenal paraganglioma. Okay, another triad, another syndrome associated is hereditary Carney-Stratakis syndrome. It is associated with GIST and familial paragangliomas. And next syndrome is neurofibromatosis 1, von Reckling-Hussen syndrome. Okay, so they are usually associated with SDH deficient GIST. These two are with SDH deficient, and neurofibromatosis 1 is usually is not deficient in SDH. The most common site is stomach in about 50%, followed by small bowel in 5%, rectum in small bowel in 25%, rectum in 5%, and small minority in esophagus, colon, and appendix. Some books have slight variation in this. Some have given esophagus in about 5% and colon 5% and rectum 1%. So this is from the NCCN guideline. They have given as 5% in the rectum and minority in esophagus, colon, and appendix. So they are histologically made up of two types of cell. One is spindle cell, and another is epithelioid cells, and some are the mixture of both the cells. So spindle cell associated tumors are more common. They are present in about 2/3 of the cases, and epithelioid cell cysts, they are more common in the stomach. Immunohistochemically, if we are saying that they are more likely to be positive for CD117 or KIT and DOG1 proteins, and they are also positive for CD34 marker. PDGFR mutated GIST, they are usually negative for CD117. Desmin is rarely positive, and SDH deficient GIST will be negative for SDHB. SDHB is usually subunit is taken as the marker. So molecular pathology, this it is very important in case of GIST because it is both prognostic and predictive of tumor response. Gain of function mutation usually occurs in KIT and PDGFR proteins and oncogenes, and they are present on the chromosome 4, at chromosome 4 Q12, long arm of chromosome 4, and they are present in about 80% of the gist. So then the mutation in KIT and PDGFR oncogene is present in about 80%. Usually they are exclusive, mutually exclusive. If there is activating mutation of KIT, then there won't be activating mutation of PDGFR. PDGFR is platelet derived growth factor receptor A. So for activation of KIT protein, KIT receptor, usually the ligand binds to the receptor, and there is dimerization of the receptor. Two molecules of the KIT, they combine together and they activate the downstream pathway. But in case of mutated, so they are usually in dimerized state or they do not require dimerization. So downstream pathway is activated, and the main downstream pathways are RAS, RAF, MAP kinase pathway, and other is PI3K, AKT, mTOR pathways. They are usually involved in protein synthesis, cell growth, cell survival. Usual mutations are deletion, insertion, and missense mutations. For SDH related tumors, usually it is the succinate dehydrogenase. It is found in the mitochondria. It has four subunits: SDH A, B, C, and D, and mutation occur in one of the subunit. And normally it is involved in dehydrogenation of succinate, which is in downstream pathway. It is involved in hypoxia induced factor 1 alpha. So if the protein is deficient, SDH is deficient, there is increase in hypoxia induced factor 1 alpha, and it further leads to growth signaling by insulin growth factor, VEGF, and angiogenesis. So this is the pathway for SDH related GIST. So in KIT oncogene, mutation usually affects the juxtamembranous domain of the KIT. It is in the exon 11. It is along the membrane. This is called the juxtamembranous domain. It is present in about 70% of the GIST. Exon 9 mutation is the extracellular domain of the KIT receptor, and it is present in about 10 to 11%. And exon 13 to 17% mutations, they are they occur in the intracellular ATP binding pocket of the KIT receptor. They are very less than 1% the cases. And PDGFR mutation, it is present in about 10%. Some have given about 2 to 5%. So PDGFR mutations are very less common compared to the KIT oncogene. They usually occur in exon 12, 14, and 18, out of which exon 18 mutation are most common. And among 18 mutations, also D842V mutation is the most common. 70% of the exon 18 mutations are D842V, and it has a predictive role. It is associated with lack of sensitivity to approved tyrosine kinase inhibitors, that is imatinib. And other mutations of exon 18, like deletion of codons, it is not associated with lack of sensitivity. So they are sensitive to imatinib therapy. So exon 9 mutation of KIT, they usually occurs in small bowel cysts, and PDGFR mutation, they are usually found in the stomach cancers. So 10 to 15% of the cysts, they are wild type for KIT and PDGFR mutation. So they do not have mutation in KIT and PDGFR oncogene. They include SDH deficient GIST, NF related GIST. As I already told in previous slide, NF are not associated with SDH deficiency, and others include mutation in the BRAF V600E oncogene, RAS mutation, or there can be ETV NTRK gene fusion. These mutations were also found in colorectal cancer, BRAF in melanomas also. They occur in the downstream pathway. Like in this pathway, I told if there is mutation in the RAF BRAF protein, and they are associated with uh, GIST, which are wild type for KIT and PDGF. That is, they are more commonly associated with sporadic GISTs. So coming on to the syndromic GIST, SDH deficient GISTs, they are wild type. They have mutation in SDH A, B, C, or D subunit, more commonly tested for SDH-B, and this protein is used in mainly involved in Krebs cycle and mitochondrial respiratory cell pathway. And Carney's triad is associated with SDH deficient GIST, as we have already known in previous slide that associated with GIST, pulmonary chondromas, and extraadrenal paragangliomas. They are more common in children and young adults with female sex, and they are more likely to be present in stomach and are multifocal. They commonly metastasize to lymph node, in contrast to the sporadic GIST and those associated with KIT and PDGFR mutation. Normally, GISTs do not metastasize to lymph nodes, but SDH deficient GIST, which are associated with the syndromes like Carney's and Carney's statistic syndrome, they are more likely to metastasize to lymph nodes, and they have an indolent course. And an NF1 related GIST, they are likely to be SDHB positive. They also have indolent course and like also multicentric like SDH deficient GIST. But in contrast to SDH deficient, they arise more commonly from the small bowel. So revising our genetic mutations, KIT mutation is present in about 70 to 80%, and most common mutation is in the exon 11, and it does not have any predilection for stomach or small bowel. Exon 9 mutation is next common in about 10%. They are more common in small bowel and colon. Okay. So other mutations are less common. PDGFR mutations, among this, the most common is D842V mutation in exon 18, and they are more likely to be present in the stomach, mesentery and omentum, less likely in the small bowel. And other wild type tumors, they include SDH mutations. They are more common in stomach, and NF related 1 tumors, they are rare but more commonly present in the small bowel. The other mutation, are BRAF mutation, is also common in some tumors. So clinical presentation, they usually present late because of their outward growth pattern, because they do not grow into the uh, intraluminally, and they more likely to grow into the peritoneal surface side. And one fourth of the GIST, they present as an acute abdomen because of the tumor rupture, GI obstruction, or appendicitis like pain. Another one fourth, they are discovered incidentally during other diagnostic assessment, and other patients, they present with early satiety, abdominal discomfort due to pain and swelling, and some may have features of GI bleed, intraperitoneal hemorrhage. If not presenting as acute abdomen, there may be a chronic type of intraperitoneal hemorrhage or with fatigue related to anemia. Most common site of metastasis is peritoneum and liver. Lung and bone are rare, and regional lymph node metastases are not typical of GIST. Exception is wild type GIST occurring in children and those occurring within the syndromes. Investigation for GIST is upper GI endoscopy. As you can see, they are usually submucosal lesions with intact mucosa, and biopsy to be done in case of friable tumors. And but there is risk of bleeding with the biopsy. And endoscopy or EUS guided biopsy can be tried in case of submucosal lesion. EUS guided biopsy is done. If there are metastatic sites, then ultrasound or CT guided biopsy to be done prior to any surgical intervention. So in pathological report, we should know about the location of the tumor, size of the tumor, and third thing is the mitotic rate, which is measured in the most proliferating area of the tumor and reported as mitosis per 50 high power field. So these three factors in pathology are important prognostic factors. So imaging include CT or MRI to characterize the abdominal mass, to evaluate its extent, and also the presence or absence of metastasis. PET scan is a very important imaging investigation. It in GIST, it differentiate active tumor from necrotic or inactive scar. It differentiate malignant from benign and recurrent tumor from benign changes. It is also used to clarify ambiguous findings seen on CT or MRI and to assess the complex metastatic disease. And it is as an important modality to monitor the response to therapy. So PET is recommended in all GISTs if available. So staging for GIST. So staging is similar, like in anal canal also. T1 less 2 centimeter or less, T2 more than 2 less than 5 centimeter, T3 more than 5 centimeter but less than 10 centimeter, and T4 is more than 10 centimeter. N1 in regional lymph nodes are present. And grading, low is 5 or less mitosis per 5 millimeter square or 50 high power field, and high grade is more than 5 mitosis per 50 high power field. So we'll discuss the small intestinal gist and in this thing. Uh, Stage 1 is T1, T2 with low mitotic rate. Stage 2 is T3 with low mitotic rate. Stage 3 is 3A is T1 with high mitotic rate or T4 with low mitotic rate. They have, and the staging is based on the rate of the metastatic potential, which we'll discuss in the next slide. 3B is T2 to T4 with high mitotic rate, and stage 4 is any node positive or distant metastatic tumors. If you compare small intestinal gist with gastric gist, for stage to comparison, size to mitotic rate comparison, small intestinal gist have higher stage than gastric gist. So T1, T2 tumor with low mitotic rate are stage 1A as compared to stage 1 in uh, small intestine, and T3 low mitotic rate is only stage 1B. So it was stage 2 in small intestine. And T1, T2 high and T4 low is stage 2. Whereas in T1 high and T4 low is stage 3A. Okay. And again, T3 with high is stage 3A, and T4 with high mitotic rate is stage 3B. So if you compare the potential of developing metastasis, less than 2 centimeter with low mitotic rate have only 0% in gastric and non-gastric gist. With more than 5 mitosis, high mitotic rate, size less than 2 centimeter, in gist is only 0%. But with non-gastric, it is about 50 to 54%. So it is stage 2 in gastric and becomes stage 3A in non-gastric small bowel tumors. So all tumors with high mitotic rates, they will have high metastasis rate in non-gastric gist compared to the gastric gist. So this was another classification system used. This is called Joensuu modification of National Institute of Health consensus classification. It categorized into very low risk, intermediate risk, and high risk based on the tumor size, the mitotic index, and the primary site. So all tumors with intermediate and high risk, they were advised for adjuvant therapy and only follow up for very low risk and low risk tumors. So the question is the risk of progressive disease in a patient. For a patient with small intestinal gist measuring less than 2 centimeter with more than 5 mitosis per 50 hour, high power field is. We have just discussed it. So less than 2 centimeter with more than 5 mitosis. Stage 1 T1 high grade. So answer is D in this case. It is high, but not for this thing. Like in the previous slide, we'll see. The risk of developing in less than 2 centimeter with more than 5 mitosis per 50 in non-gastric gist, it's about 50 to 54%. Okay. If the size increases to more than 5, more than 2, less than 5, it becomes around 70%. In less than 10 centimeter tumor, it is about 85%, and more than 10 centimeter is very high, about 90%. So, so answer to the question is 50%. So management of gist, all gists with more than 2 centimeter size and those who are symptomatic, regardless of the size, should be resected. And those tumors with less than 2 centimeters and without any symptoms can be considered for conservative and periodic follow-up. So NCCN suggests those tumors, small gastric gists, less than 2 centimeter. This is only for the gastric gists. Less than 2 centimeter and proven with EUS guided FNAC. If there are no high risk features, then endoscopic surveillance to be done, and if there are high risk feature, then complete surgical resection to be done in these cases. And if it is a small bowel disease, then complete resection to be done even with the less than 2 centimeter size. So if the tumor is resectable with minimum morbidity, then go ahead with the complete resection. And if there is significant morbidity associated with the resection, like for duodenal carcinomas, in which the big surgery has to be done, those tumors requiring extensive resection, they should be considered for neoadjuvant imatinib therapy to decrease the surgical morbidity and then further assessment. The goal of surgery is R0 resection. Those patients with undergoing R1 resection, their prognosis is still better than those undergoing R2 resection. And tumor rupture and violation of tumor should be avoided during the surgery because it is associated with high risk of recurrence. And lymphadenectomy is usually not required in this. So, what are the minimally invasive techniques for? It is more commonly used in stomach gist, and tumors up to 5 centimeter can be treated with minimally invasive surgery, and their specimen are corrected in the endo bag to prevent spillage. And a classification system has been devised to classify the resected gastric tumors with minimally invasive. So if it is type 1 is located in the fundus or the greater curvature of the stomach, they can be handled with laparoscopic stapled partial gastrectomy. You can apply the staplers. And if it is involving the antrum and pre-pyloric region, it is type 2, and they are usually treated as laparoscopic distal gastrectomy. Those with type 3 located near the lesser curvature of the stomach, they are approached through transgastric approach and usually assisted by the endoscopy assisting in the transgastric resection of the lesser curvature tumor. So those tumors which require extensive resection like total gastrectomy, Whipple's, rectal resection, etc., they should be treated with neoadjuvant imatinib therapy, and duration of therapy is generally 6 to 12 months before reassessment. So if there is a stable disease or some response, continue with the same dose of imatinib or surgery if possible. I'm sorry. And if there is progression of disease with initial imatinib therapy, then if surgery can be done at that time, surgery to be done. And if surgery is not feasible, then to be continued in case as in the progressive disease. We'll see in the next slide. So which factor will affect our surgical decisions are: if presence of multifocal and multicentric disease, lack of sensitivity to the wild type, lack of sensitivity of wild type GIST to available TKI. This also alters our surgical decision. So in these type of cancer, those who are not sensitive to TKI, surgery to be done more liberally than in KIT mutated GIST. So even if they have to undergo major resection like Whipple's or rectal resection, because we know that it will not be sensitive to imatinib therapy, and surgery is the only option available to us. So it is done, more extensive resections are allowed in this day. So next question, a 50-year-old healthy male presented with GIST and CT imaging showed a 7 centimeter tumor that is amenable to surgical resection and no distant metastasis. He underwent surgery and revealed a 7 centimeter GIST with 7 mitosis per 50 high power field and KIT mutation in exon 11. What should be offered next? So what is your answer? Whether to be follow up with CT scan of abdomen and pelvis every 3 monthly, imatinib at 400 milligram daily, imatinib at 400 milligram BD, or adjuvant chemotherapy with doxorubicin and radiation therapy. We will know the answer to this thing. We'll discuss this in detail, but I want to know your answers. What? C. Anybody else? B. To answer to this question, first we'll know the details in the question. It is a 7 centimeter GIST. So it is T3 and 7 mitosis per high power field. So it is a high grade tumor. T3 with high grade tumor, and it is a small intestinal GIST. All factors are high with the metastatic rate in about 70 to 80%. And the only good factor is KIT mutation in exon 11. Okay. So it is sensitive to imatinib. Okay. So initial tumors which are sensitive to imatinib, they should be started with 400 milligram daily dose. So answer is B in this case. So we'll discuss it later that those patients who have progressed, like in progression to imatinib therapy. So one option then comes is starting imatinib at 400 milligram BD dose. So if we are starting as first time, the imatinib to be started at 400 milligram OD. Okay. So adjuvant therapy for completely resected tumor and no previous imatinib, and in low risk disease it is to be observed, and those with high risk, intermediate or high risk, they should be given adjuvant imatinib. So our last patient was in the question was high risk patient. So adjuvant imatinib is category 1, and those patients with completely resected after pre-operative imatinib, if it had been given previously and it was non-progressive on pre-operative imatinib, then consider continuation of the adjuvant imatinib. Okay, and then follow-up to be done every 3 monthly for high risk tumors, every 3 to 6 monthly till 5 years, and then annual. Okay. So adjuvant therapy, imatinib is the standard of care. It substantially improves relapse-free survival, and there is a trend to lose the benefit in a time span of 1 to 3 years from the end of therapy. So if we stop the adjuvant therapy after like 6 months, then within 1 to 3 years of stopping therapy, the tumor will start growing. If it has to come, it will grow again. So some consider that TKIs delay the recurrence, but do not avoid a relapse. So they can delay it, but do not avoid the relapse. So some institutions, they prefer longer duration of therapy in adjuvant treatment. Right? So it is recommended that adjuvant therapy with imatinib should be given for at least 3 years in patients who are having a significant risk of relapse, about 30 to 50% range. Double dose of imatinib is given in 800 milligram dose is given for advanced GIST patient with exon 9 KIT mutation GIST. In our question, the KIT mutation was at exon 11. So it has been found that those patients with exon 9 KIT mutation, they do not benefit with 400 milligram OD dose. They should be given a double dose. So in the same question, if it had been exon 9 KIT mutation, then the answer would have been 400 BD. So adjuvant treatment in syndromic GISTs, it is not recommended as of now because there is lack of evidence to support to response to imatinib therapy. So imatinib is given 400 milligram OD and 800 milligram in case of exon 9 KIT mutation, and progression of imatinib 400 milligram dose. Sunitinib is given as 50 milligram daily for 4 weeks in a 6-week cycle, or 37.5 milligram continuously. Regorafenib is third line treatment for progressive disease. It's 160 milligram given for 3 weeks in a 4-week cycle. Usual side effects of imatinib are fatigue, edema, mild diarrhea, and anemia, and less frequent toxicity are neutropenia and skin rash. Overall, otherwise, it is a well-tolerated drug. So for metastatic and locally advanced disease, imatinib continuously giving indefinitely is the treatment of choice. But limiting factor for giving it indefinitely is development of secondary resistance for imatinib. So initial tumor burden is a major prognostic factor for locally advanced and metastatic disease, and mutational status is a major predictive factor. Those with exon 11 mutation, as I told, are most sensitive to imatinib. Exon 9 mutations They respond with higher dose. PDGFR mutations are also sensitive to imatinib except for D842V mutation. They are less sensitive to imatinib. They are non-sensitive to imatinib, not less sensitive. And SDH deficient GIST, they may be slight sensitive to sunitinib and regorafenib therapy, but they are not sensitive to imatinib. So before going further, we'll take another question, that is 63-year-old female taking 400 milligram of imatinib for a metastatic gastrointestinal stromal tumor, and she noted to have progression of disease throughout her peritoneum, and patient has good status, good performance status, and does not complain any side effect of imatinib. So there is now progression on 400 milligram of imatinib. So whether change the therapy to regorafenib, change therapy to doxorubicin, increase dose of imatinib to 400 milligram, or resect all the enlarging or new lesions. So for this, answer is C, that is correct. That is increase the dose of imatinib to 400 milligram. So we have to consider other options also. Why not resect all the enlarging and new lesions? That would have been better next treatment line if it was resectable in this case. But in seeing in the question that she was found to have progression of disease throughout her peritoneum, so this is unresectable disease. If there had been only one or two tumor tumor areas where there was progression, then we could have gone ahead with resection of the tumor and continued with the same 400 milligram of imatinib. But in this case, increase the dose to imatinib to 400 milligram BD because it is unresectable. So secondary resistant is the limiting factor of imatinib, and mean time to event, that is development of secondary resistance, is about 2 years. And various mechanisms of resistance are, there can be occurrence of new mutation in the same oncogene, that is in the kit. If there had been previously 9 or 11 mutation, exon mutation, they develop exon 13, 14 or 17, 18 mutation. In case of PDGFRA, there is mutation may acquire D842 mutation if it was not present previously. And there can be oncogene amplification or alteration of the alternative pathways, and there can be changes in the pharmacokinetics of the drug. These are the various mechanisms for development of resistance. So how to delay resistance? First one is surgery of the residual responding disease. So recommendation is remove, if you can completely resect all the lesions, then they should be taken for surgery, and they are the ideal candidate for complete surgical removal. So in our previous question, she could not undergo complete surgery of all the tumor deposits. So in that case, we have given imatinib. So if there is a progressive disease and it is limited to some sites, then continue with the same dose of TKI with either one of the following, like resection if feasible, ablation of the tumor, embolization, chemoembolization in case of liver only tumors, palliative RT in case of bony mets. If it is not feasible, any of these three are not possible, then dose escalation of imatinib as tolerated, or change to sunitinib therapy. If dose escalation is also, patient is not likely to tolerate the dose imatinib better, then change to sunitinib and then assess the response to therapy. But if there are generalized widespread systemic disease, then dose escalation of imatinib or change to sunitinib. This is category 1. So in previous question, If there had been one option of change to sunitinib, then according to NCCN, it is the category 1. But next best should be imatinib. On the best treatment would be change to sunitinib. Okay. So if there is progression on sunitinib, then regorafenib to be considered and assess the response. So in case of progression, we do not want to utilize uh, all our drugs at once. So initial dose escalation to imatinib, then change to sunitinib is preferred. So if disease is progressing despite imatinib, sunitinib, regorafenib therapy, then either clinical trial or repeat biopsy to see for any other targeted lesions and only best supportive care. Okay. So second line therapy is sunitinib. It's also a tyrosine kinase inhibitor. It inhibits KIT and PDGFR protein, and it also has anti-angiogenic activity. There is inhibition of VGFR 1, 2, 3, and activity is against exon 9 mutation and mutations of the ATP binding pocket, that is exon 13, 14, 17, 18. And randomized control trials have shown increased progression free survival by 5 months, and it is as such less tolerable than imatinib, with fatigue and hand foot syndrome are the main side effects. Regorafenib is third line treatment. It's active against KIT and PDGFR and also against VGFR receptors 1, 2, and 3. It is associated with 4 months progression free survival. Side effects are hand foot syndrome, hypertension, fatigue, and diarrhea. Other therapies that can be used in case of progression are sorafenib, nilotinib, dasatinib, and pazopanib. Dasatinib is useful for PDGFR 842 mutation, and these things have shown activity in GIST resistant to imatinib and sunitinib. So first line therapy is imatinib as category 1, and another one is avapritinib for GIST with PDGFR mutation in the exon 18, including 842 mutations. So avapritinib, if exon 18 mutation with 842V mutation is there, then avapritinib is one option. Second line therapy for unresectable and metastatic disease, sunitinib. Third line therapy is regorafenib, and fourth line is ripretinib. These are mentioned in the NCCN. These ripretinib, or like I mentioned in the previous, sorafenib, nilotinib, dasatinib, and pazopanib are also options which can be considered as fourth line. So evaluation of tumor response. With TKI, there is a peculiar pattern of tumor response which is seen that there is lack of tumor shrinkage. Tumor size remains the same, but there is change in the tumor tissue and metabolic activity. And if patient is symptomatic, the first thing he has is relief of symptoms with start of TKI within weeks of starting it. And metabolic response as assessed with PET scan is very fast in case of GIST responding to TKI. It is like a metabolic switch which is turned off within days of starting GIST. And PET negative tumors, they need further investigation with the help of CT or MRI to evaluate for the tumor lesion, the radiological response in the tumor, like decrease in the size and knowing about the tumor heterogeneity. And CT scan is useful in determining the decrease in size of the responding lesion and with decrease in contrast enhancement. MRI shows hypointense signaling on T1 weighted image and hyperintense on T2 weighted image, and decrease in contrast enhancement in those tumors which have responded to TKI. And Choi criteria used for CT changes in GIST. So response is more than 10% decrease in the size of the tumor and more than 15% reduction in the density of the tumor. And progressive disease is increase in the tumor size more than 10 centimeter. Okay. And partial uh, stable disease or partial response is less than this. So we should know the response and progression of the disease. So which of the following is not a prognostic factor for gastrointestinal stromal tumor in modified National Institute of Health criteria? It's a simple one. Tumor size, tumor location, mitotic index, or age of the patient. Yes, answer is age of the patient, because tumor size, T stage, location, gastric, non-gastric, or mitotic index, they are all very important parameters which are prognostic. So this finishes our gist topic also. And we'll be starting next with the small bowel neoplasms. So small bowel neoplasms, they account for about 4% of all GI malignancies, and male to female ratio is slightly more commoner in males, and median age is about 66 years, more common in African Americans. And among small bowel tumors, most common are the carcinoid tumors. Uh, Prevalence is about 37%. Then adenocarcinoma. Third is lymphoma, and fourth is GIST or other tumors. So most common, if it is asked, it's carcinoid tumors. Small bowel cancers, 50% occur in the duodenum. The most common site for small bowel cancer is duodenum, and most common in the duodenum is adenocarcinoma. And jejunum, 30%, and ileum. Proximal ileum, lymphoma is more common. Distal ileum, carcinoid tumors are more common. So why there is low susceptibility for small bowel to develop malignant change? It is because of the rapid transit of intestinal content, because of the short exposure of mucosa to carcinogenic, because of the liquid content, and moderation of mucosal irritation by the liquid nature of the small bowel content, low bacterial overload, and there is high concentration of lymphoid tissue. So what are the risk factors? Advancing age, inherited syndrome like colorectal cancers, they are associated with small bowel tumors. FAP, familial adenomatous polyposis, is associated with duodenal or periampullary carcinoma. HNPCC, there is about 1 to 4% lifetime risk of small bowel cancers. Moot associated polyposis, about 4% lifetime risk of duodenal cancer. And Peutz-Jeghers syndrome. And other risk factors are inflammatory bowel disease. Crohn disease is associated with risk factor of developing small bowel cancer by about 60%. They are more common in men and in the distal ileum, and present at site of loops and strictures. In this, a peculiar inflammation dysplasia carcinoma sequence is seen, as in contrast to this dysplasia adenoma carcinoma sequence. So KRAS and P53 gene mutation overexpression is seen in some of the patients who develop Crohn's disease related small bowel cancer. Other risk factors are celiac disease or celiac sprue. It is associated with increased enteropathy associated T cell lymphoma, in some cases adenocarcinoma. EATL is present in about 39% of the patients with severe celiac sprue, and they have normal adenoma carcinoma sequence, and they have more predilection for developing tumor in the jejunum. Another is IPSID. IPSID is immunoproliferative small intestinal disease, and it is associated with diffuse small intestinal lymphoma. Other malignancies like development of colorectal malignancies and as part of syndromes, They are associated with increased risk of small bowel cancer, which we discussed, and modifiable risk factor associated with small bowel cancer are similar those associated with colorectal cancer, like in taking salt cured or smoked food, high in intake of red meat, refined carbohydrates, alcohol, obesity, etc., all associated with small bowel cancer, and increased risk of developing small bowel carcinoid in those people who are working in the wholesale food and beverage industries and manufacturing of motor vehicle footwear or metal structure industries. H. pylori and Campylobacter jejuni infection, they are associated with small bowel lymphomas. What are the clinical features? Duodenal tumor, they usually present with blood loss, frank or occult blood loss, and biliary obstruction if they are at the periampullary region. Abdominal pain can occur, and some may present with symptoms of gastric outlet obstruction in the form of recurrent vomitings. Jejunal and ileal tumors, they present with partial or complete bowel obstruction, perforation, non-specific abdominal pain, asthenia, etc. And adenocarcinoma is most commonly associated with abdominal pain and obstruction. And sarcomas, they usually present with bleeding, like cysts, and lymphomas more commonly present with perforation. The investigation for small bowel cancers are gastric and colonic endoscopy to be done. And initial investigations are endoscopy, ultrasound, and barium examination. Further investigation with enterography with CT or MRI. MR is more accurate than CT enterography. And for ampullary lesion, endoscopic ultrasound, CT angio for bleeding sites, and capsule endoscopy. It identifies about 50% of the new small bowel cancer lesion and 80% of the 87% of the all lesion, and the miss rate is very low. And but it is contraindicated in obstructing lesions. So if in case of obstructing lesion, it gets stuck at the site and it will need an emergency surgery. Double balloon enteroscopy, it permits evaluation of the entire small bowel along with ability to take a tissue for biopsy. So it detects small bowel lesions including areas of ulceration, stenosis, GI bleed with a sensitivity of 74 to 81%. For neuroendocrine and carcinoid tumors, somatostatin receptor scans like octreoscan, MIBG scans are helpful in diagnosis and localization, and PET scan may be useful as initial diagnosing and staging for small bowel adenocarcinoma, lymphomas, and GIST. FDG PET for all these small bowel adenocarcinoma, lymphoma, and GIST, and but gallium dotatate PET scan for carcinoid and neuroendocrine tumors can be used. Discussing the small bowel adenocarcinoma, it is the most second most common small bowel cancer subtype. Most common is carcinoid. It's six to develop in 6 to 8 decades, and most common adenocarcinoma develop in the duodenum, 50 to 70%, followed by jejunum, and lastly in the ileum. They usually develop in the intestinal stem cells. Carcinoma, these stem cells are located at the bottom of the crypts of lubricant and in the epithelial proliferation zone. They usually utilize the WNT pathway, which we have studied in the colonic cancer in the last class. WNT pathway is main. It is useful in maintaining the homeostasis and self-renewal pathway. Any abnormality in WNT pathway, it forms the adenoma carcinoma sequence. Okay. So other mutation which occurs similar to colonic cancer are P53 mutation, that it's a late mutation in adenoma carcinoma sequence, beta catenin, HER2, APC gene mutation, it is the first mutation to occur, KRAS, BRAF, and MMR gene. Various histological subtype of adenocarcinomas include adenosquamous, adenocarcinoma with endocrine, neuroendocrine, or mesenchymal differentiation. IHC usually they are positive for CK7 and CK20 in contrast to colorectal cancer which are CK20 negative. It is positive for CEA and it is negative for prostate related marker AMACR. AMACR. It is positive in colorectal cancer but negative in small bowel cancers. Screening is not recommended for colorectal cancer because of low incidence, but those patients with high incidence, high risk, like those with celiac disease, Crohn disease, Peutz-Jeghers, cystic fibrosis, and those presented with clinical features like long-term, long-standing anemia, refractory or new onset stricture unexplained um, weight loss should be evaluated with capsule endoscopy or MRI enterography. In case of familial adenomatous polyposis, which have high incidence of developing duodenal cancer, screening to be done with upper GI endoscopy. The criteria used for endoscopic surveillance is Spiegelman's criteria, as we studied in last class, and starting at age of 20 to 30 years prior to colectomy. So this is the Spiegelman's criteria in based on the duodenoscopic finding, like in no polyposis, minimal polyposis, and mild to moderate polyposis. Screening recommendation change. So what are the investigation for small bowel adenocarcinoma? They are similar, like abdominal pelvic CT or MRI and chest CT. PET scan is not indicated in small bowel cancer. Similar recommendation as in colorectal cancers. So PET scan is not indicated. Esophagogastric duodenoscopy with endoscopic ultrasound for duodenal cancer. Most commonly used transducers are 5, 7.5, 10, and 12 megahertz transducer for EUS. CA99 and CEAs are the tumor markers, and clinical study for celiac disease, biopsy for pathological repair, and mismatch repair testing. So staging is TIS is invades the lamina propria and submucosa. T1 is lamina propria, T1B submucosa. So T1A is uh, in colorectal cancer, CK7 is positive, CK20 is, yeah, I guess I mentioned it. CK20 is positive. Mm. So did I will see in the staging? What did I mention in the colorectal cancer? CK20 is in this I mentioned is negative. In this also, CK20 is positive for colorectal cancers also. Okay. So coming on to the staging, T1 tumors they invade the lamina propria, and T1B it invades the submucosa. This is in contrast to the colorectal cancer, in which T1 tumor, T1, and this, if it is invading into lamina propria, this is still considered carcinoma in situ in colonic cancers, but it becomes T1A in small intestinal cancer. T2 is invading the muscularis propria. T3 it is invading into the serosa and into the non-peritonialized perimuscular tissue, and T4 if it is involving other organs. Metastasis 1 to 3 1 or 2 lymph node is N1 and 3 or more lymph node is N2. Okay. So stage 1 is T1, T2, stage 2 is T3, T4, and any node positive is stage 3. and stage 4 is M1 disease. So for small intestine, AJCC recommends about 8 lymph nodes to be harvested. In contrast to colonic, in which 12 lymph nodes is the recommendation, in this 8 lymph nodes to be harvested. So regional lymph node for primaries, like for duodenum, retropancreatic, superior, inferior pancreatic or duodenal, hepatic artery node and superior mesenteric are the regional lymph nodes. And for jejunal and ileal, terminal ileus, cecal and ileocolic lymph nodes, superior mesenteric and are the locoregional lymph nodes. So stage wise presentation is about 1/3 present in stage 4, another 1/3 present with stage 3, and 1/3 present with stage 2. Only 4 to 10% present in stage 1. So in stage 2, 3, and 4, 1/3 of the patients present. And overall survival, it is 63% for stage 1, 48% for stage 2, 32% for stage 3, and only 4% for stage 4 cancer. Okay. So overall survival is dismal for small bowel cancer even in stage 1. So poor prognostic factors are advancing age, male gender, T4 tumor, high lymph node involvement and high ratio, duodenal primary followed by ileal primary. So duodenum, presence of tumor in duodenum is associated with poor prognosis. Poorly differentiated tumor, metastatic disease, R1, R2, that is not completely resected tumors. In molecular, we see SIMP status, that is CpG island methylator phenotype status, E cadherin, and aberrant B catenin expression. They are associated with poor prognosis. CIMP was associated with BRAF mutation commonly. So, treatment for stage 1 to 3 is R0 resection. It offers the longest survival. It is the best treatment modality for stage 1 to 3 localized disease, and 5-year survival, it ranges from about 27 to 54% in resected patient versus 0% in unresectable disease. So surgery, optimal surgery for duodenal cancer is segmental resection, or if possible, otherwise if it is involving at the ampullary region, then pancreatic or duodenectomy to be done. Jejunal and ileal small bowel adenocarcinomas, segmental resection with, if it is involving near the ileocecal valve, right hemicolectomy to be done. What is the role of adjuvant chemotherapy? There is a mixed response, not well studied in small bowel cancer, but it is given in lines similar to the colorectal cancer, and the CI database has shown that 5-year survival is improved following adjuvant chemotherapy. But CA database has shown superior 5-year survival for similar adjuvant chemotherapy in colorectal cancer compared to small bowel cancers. Okay, so for giving that chemotherapy, it will give better result in colorectal cancer than with the small bowel adenocarcinoma, but there is no additional overall survival benefit in small bowel adenocarcinoma compared with the surgery alone. But NCDB database, National Cancer Database Registry, they have shown that stage 3 small bowel adenocarcinoma, this subgroup may benefit from the adjuvant therapy. And there is some role of HIPEC in patients who have limited peritoneal carcinomatosis. So HIPEC followed by adjuvant chemotherapy has been found to improve median overall survival by 36 months compared to 12 months in case of no HIPEC or cytoreductive surgery is not done. So there is no much proven role of adjuvant chemotherapy in small bowel cancer. For duodenal cancer with early stage, no nodal metastasis observation, T3N0 with MS stable, microsatellite stable or proficient MMR, you can consider for leucovorin single agent treatment. And those with T4 disease and MSS, they can be considered for observation or Folfox Capox chemotherapy based on similar in lines with colorectal cancer or any node positive disease to be uh, given Folfox or Capox chemotherapy, or single agent can be given, or chemoradiation in case of positive margins. So these are just recommendations, and there is no trials to suggest as it is a category 1. They can be observed or given a single agent therapy, or can be given like Folfox combined agent therapy. Surveillance is after adjuvant treatment, surveillance every 3 to 6 monthly for 2 years, then every 6 monthly for 5 years. And CA and CA99 to be measured at every time, and CT to be done only 6 to 12 monthly for 2 years and every 12 monthly for next 3 to 5 years. PET scan is not indicated, and capsule endoscopy is also not indicated. That was for duodenal cancer. For jejunal or ileal cancer, also recommendations are similar. Observation or single agent therapy, or in T3 with high risk features or with any node positive, Folfox and Capox is recommended by NCCN. In case of metastatic disease, those patients who are appropriate for intensive therapy, those who are fit to tolerate intensive therapy, they are usually started with the combined agent therapy with Folfox, Capox, with or without bevacizumab or Folfoxiri. And those who are not appropriate for intensive therapy, they should be given single agent therapy. And then when there is a progression, and based on the mismatch repair status, on second line they can be, in case of MSI high, therapy should be pembrolizumab or nivolumab. Checkpoint inhibitors can be considered in case of MSI high, like in colonic cancer they have shown sensitivity in case of microsatellite instable disease. So 5-FU chemotherapy regimen alone, or most often in combination with platinum agents, are considered effective, and 18 to 54% objective response, and there is limited progression-free survival and overall survival gains in metastatic disease. So next question is, a 50-year-old gentleman presents with bloating, tarry stools, and endoscopy revealed a mass in the duodenum. It is moderately differentiated adenocarcinoma. There are 3 nodes which are involved with the tumor, and CT scan showed no distant metastasis. What is true regarding small bowel adenocarcinoma? Anybody else? Duodenum is the most common location of adenocarcinoma. Jejunal ileal tumor associated with worse outcomes. Stage 3 is associated with 63% survival. Adjuvant with FOLFIRI is standard for. So in this case, answer is A, that is correct. Adenocarcinoma, most common location is in the duodenum. Jejunal and ileal tumors are not associated with worse outcome. Actually, they have better outcome than duodenal adenocarcinoma. And stage 3 tumor, they are that is also wrong. 63% survival is seen in stage 1 tumors, and stage 3 is very less. And adjuvant therapy with FOLFIRI is not the standard, because there is no standard for adjuvant treatment in adenocarcinoma. You can give Folfox, Capox, or single agent 5-FU. Even then, irinotecan, as it was not given in adjuvant therapy for colon, also there is no use of giving irinotecan in adjuvant therapy. So it is not recommended also. So answer is A. Coming on to the carcinoid tumors in small bowel, it is the most common histological type of small bowel cancer. Risk factors are not known, but celiac sprue and some conditions like multiple endocrine neoplasia, MEN1, and neurofibromatosis, they are associated with slightly increased risk of small bowel carcinoid. They are slow growing neoplasm. They arise from the neuroendocrine cells of Kulchitsky, and they are capable of producing serotonin. So this we'll know in the later slide, that production of serotonin associated with carcinoid syndrome. Okay. So primary location, 75% of the carcinoid, they occur in the GI tract, and 44% in the small bowel, 19% in the rectum. Okay, among less common are the lung, bronchus, and even lesser common are liver, pancreas, and gonad. And among the small bowel carcinoid, the most common location is in the ileum, which account 49%, and followed by duodenum and jejunum. So duodenal NET carcinoid, they behave differently from small bowel and neuroendocrine tumor, and they are staged along with the ampulla of Vater tumors. Histologically, the characteristic features is mucosa is typically intact and submucosal infiltration is the rule. Okay. So tumor infiltration and fibrosis occur into the muscularis mucosa and surrounding mesentery. Solid nest of cells with small bowel, small round nuclei are the most common histological pattern. In all neuroendocrine tumors, you'll see the small round nuclei is seen, and lymphovascular and PNI is common in carcinoids. Grading is based on mitotic rate and Ki67 index. We'll know all the grading also when we do the staging. Molecular aspects of carcinoid are loss of chromosome, loss of heterozygosity at chromosome 18, and at 9p, chromosome 16p, and gain of function mutation of chromosome at chromosome 14q, that is the locus for gene encoding anti-apoptotic protein DAD1. These are some of the molecular features seen with the carcinoid tumors. And presenting complaint, usually they are vague with abdominal discomfort, borborygmy, and pain can occur. They are most likely indolent course and usually present late. And some present with carcinoid tumor. It is an hormonally induced symptom complex. So because of release of serotonin, histamine, tachykinin into systemic circulation, there are symptoms produced which are like flushing, sweating, diarrhea, wheezing. They occur, and valvular cardiac disease complication occur in about 50 to 66% in patient with carcinoid, and they are because from the systemic circulation they reach the right side of the heart. So tricuspid and pulmonary valves are more commonly involved, leading to tricuspid regurgitation and pulmonary stenosis. Otherwise, tricuspid stenosis and pulmonary regurgitation can also occur. And it is indicative of liver metastasis or retroperitoneal disease. So usually if tumor secretes serotonin, It enters the portal circulation and it is metabolized by the liver. So those tumors which has already developed into and their metastasis into the liver, or they have already invaded the structure which has systemic circulation. In those cases, tumor will directly reach the systemic circulation and it will not be destroyed by the liver enzymes in the portal circulation, thus producing the carcinoid syndrome. So 80% of small bowel carcinoid, they present with carcinoid syndrome, and it is the presenting complaint in only 10 to 17%. So most common metastasis of small bowel neuroendocrine tumors are regional or distant lymph nodes in about 70%, liver occur in about 19%, and more distant in lung and bone in only less than 1%. So various biomarkers are useful in neuroendocrine carcinoid tumors. They are chromogranin A. It is the most commonly used biomarker, and it is elevated in both functioning and non-functioning tumors. Okay. And it has a diagnostic and prognostic value. Higher levels, they reflect the increased tumor burden and poor prognosis. Chromogranin A may be falsely elevated in the setting of PPI use, chronic atrophic gastritis, in case of renal failure. Another biomarker is a byproduct of serotonin metabolism, that is urinary 5-hydroxyindole acetic acid. So measuring plasma or urinary 5-HIA is, it has a predictive role. It has a prognostic role for mortality. It is present in patients with liver metastasis, and it is present in more in hormone secreting tumors. And pancreatistatin, it also correlates with progression-free survival and overall survival. Thus, it has a prognostic significance, and it is not affected by use of PPI, pernicious anemia, gastric and gastritis, and type 1 gastric entity. Neurokinin A has a prognostic value, and its pre-treatment and post-treatment neurokinin levels less than 50 are associated with good prognosis. So majority are have prognostic value. The imaging used in case of carcinoid tumor is for localization of the tumor. CT or MRI can be used, and for localization of metastasis, MRI is better for liver, and for extrahepatic, CT is better. And other somatostatin receptor based imaging are meta-iodo, benzyl guanidine, MIBG scan, Octreoscan. Octreoscan, it uses indium 111 diethyl triamine penta acetic acid. They target the somatostatin receptors. It has a high sensitivity and specificity for detecting primary and metastatic disease. And it also helpful in preparing a functional map, that is how many metastases where all they are present in case we are anticipating radio labeled immunotherapy targeted immunotherapy or targeted therapy. Gallium labeled dotatate PET CT is more accurate than Octreoscan in initial imaging and in recurrence monitoring. So imaging, special imaging for carcinoid tumors are MIBG scan, Octreoscan, or dotatate PET CT. So staging in case of carcinoid tumor, they include both the invasion and also the size of the tumor. So T1 is invasion into the lamina propria or submucosa, like in small bowel adenocarcinoma, but less than equal to 1 centimeter in size. T2 invading the mucosa muscularis propria or greater than 1 centimeter size. T3, it invades through the muscularis propria into subserosal tissue, and T4 invades the visceral peritoneum or other organs. And regional lymph nodes are Regional lymph node metastasis in less than 12 nodes is N1, and more than 12 nodes or large mesenteric mass more than 2 centimeter size, especially those which encase the superior mesenteric vessel, they are considered to be N2 disease. So we need at least 12 nodes for staging of carcinoid tumors. Okay. So M1A is metastasis confined to the liver, M1B to at least one extrahepatic site, and M1C both hepatic and extrahepatic site. So similarly, all node positives are considered in stage 3, and T4 lesions also are considered stage 3, and metastatic sites are considered to stage 4. So another important factor is differentiation in carcinoid. They are graded into grade 1, 2, and 3 based on the mitotic index and Ki67 index. Mitotic count less than 2 per high power field per 10 high power field. In this we used 10 high power field. In GIST we used 50 high power field. And Ki index less than 3 is grade 1, and grade 2 is 2 to 10 per mitotic count per 10 high power field, or Ki index 3 to 20. In grade 3 is more than 20 mitotic count and Ki67 more than 20. Initially, they were differentiated into well, intermediate, and poorly differentiated, but nowadays, grade 1 or grade 2 are considered well differentiated, and grade 3 is considered poorly differentiated. So, what patient attribute does not impact chromogranin levels? There can be multiple answers. Please answer. Chronic kidney disease, does it alter? Use of proton pump inhibitor for reflex esophagitis, fasting state, chronic atrophic gastritis, and diet rich in avocados. Which does not impact the chromogranin levels. There can be multiple answers. Oh, I just anybody else? So for this, we know that chronic kidney disease is one of the factor which impact chromogranin level. Use of proton pump inhibitor, it affects, and chronic atrophic gastritis. These three things they affect. Fasting state is not associated with uh, it does not affect chromogranin, and also diet rich in avocados. This diet rich in avocados is more important for 5-HAA levels. That is, it increases the serotonin and further 5-hydroxy indole acetic acid levels. Answer is fasting state and diet rich in avocados. C and E. Okay. So for localized disease, treatment is jejunal or ileal. For jejunal or ileal tumors, after initial investigation, if it is local regional disease, then bowel resection with regional lymphadenectomy to be done. And in case of duodenal tumors, endoscopic resection or local transduodenal resection with lymph node sampling or pancreatic or duodenectomy is the preferred initial treatment. And after initial treatment, surveillance is done for initial 3 to 12 months, every 3 monthly. Consider biomarker level as clinically indicated, or abdominal and pelvic CT MRI, and chest CT as clinically indicated for GI tumor, but for lung and thymus tumor it is recommended. Okay, and biochemical markers used are chromogranin A, 5-HIAA. They are hydroxyindole acetic acid are most commonly used biomarkers. Okay, after 1 year of resection, it should be done every 12 to 1 year to 2 years surveillance, and it should be done with history and physical examination, biomarkers, and abdomen or pelvic CT MRI, and chest CT more in case of lung tumor, but if it is clinically indicated, then GI for GI tumors also. And after 10 years of resection, then only as clinically indicated. It is not routine surveillance is not required. So coming on to the carcinoid syndrome, it is it is associated with the release of biogenic amines and vasoactive peptide in the systemic circulation, as I've already described: serotonin, tachykinin, bradykinin, and histamine. Usually, serotonin is metabolized, but in case of liver mets or hepatic extrahepatic tumors, such as in the retroperitoneum or in involving the ovaries, testes, it is not metabolized, leads to symptoms of carcinoid syndrome. So various symptoms are flushing, which is the most common symptom. It is seen in about 94% of the patient, and it has a uniform distribution over the upper chest, neck, and face. Okay. And certain foods which provocate its the flushing, the carcinoid syndrome also, they are nuts, cheese, drugs, alcohol, stress. These are the food also which affect the 5-HA level measurement. Okay, and development of skin thickening and redness occurs in the areas where there is constant chronic flushing occur. They develop like thickened skin, thickened velvety skin develop along with redness in that distribution. Diarrhea occurs in about 80%, and serotonin is the most common cause of diarrhea. And the agent active against carcinoid diarrhea is telotristat. It is associated with significant decreased diarrhea and urinary 5-HI excretion levels. Carcinoid heart disease develops in about 40% of patients. It usually on the right side of the heart because the serotonin directly enters into the from the systemic circulation, involves the tricuspid and pulmonary valves, also endocardium, and they develop fibrosis leading to stenosis or regurgitation, and it is due to serotonin induced transforming growth factor beta secretion. This TGF beta causes fibrosis of the valves and the right side of the heart endocardium. They can another symptom is intermittent bronchial obstruction or wheezing. It occurs in about 10% of the carcinoid syndromes, and it it is symptoms are like asthma, but it is not treated like asthma, because if we give beta 2 agonist, then they additionally cause release of biogenic amines and peptides, leading to worsening of symptoms. Another symptom is pellagra. It is due to niacin deficiency. Usually the niacin developed from precursor tryptophan absorbed from the diet, and tryptophan in case of carcinoid syndrome, it is directed towards serotonin overproduction. Thus there occurs niacin deficiency, and treatment is niacin supplementation. Another thing is carcinoid crisis. It occurs in patient with carcinoid syndrome who are undergoing anesthesia or surgery and are not being blocked properly with somatostatin analogs, prior to the surgery. They develop symptoms of flushing, hypotension, bronchial obstruction, and cardiac arrhythmia. Prevention is pre-treatment with somatostatin analogs with octreotide in 25 to 500 micrograms subcutaneous or IV, 1 to 2 hours prior to procedure, and treatment if it develops during surgery, then surgical or non-surgical manipulation to be stopped. IV infusion, IV volume infusion to be given, like if serotonin causes hypotension, then you have to manage with IV fluids, and 500 to 1000 microgram of octreotide intravenously to be given, followed by an infusion of 50 to 200 microgram per hour till the symptoms are resolved. Treatment, as I said, it is somatostatin analogs, octreotide, long acting, and lanreotide or new agent is pasireotide. They ameliorate the diarrhea of carcinoid syndrome in about 40 to 80%. The symptoms of diarrhea reduce, and it also normalizes the biomarker in about 40 to 70%. And another one problem to somatostatin analog is tachyphylaxis occurs, which occur usually 8 to 12 months after treatment, but dose increment leads to further improvement in symptoms. Another agent used for treatment in carcinoid syndrome is serotonin synthesis inhibitor. Telotristat is an oral inhibitor of tryptophan hydroxylase. It reduces the urinary 5-HA levels, and it also decreases bowel movement frequency. Thus, it's used in diarrhea associated with carcinoid syndrome. Other methods to improve diarrhea are cholestyramine, pancreatic enzyme, loperamide, and tincture of opium can be used. So thus, patient have features of carcinoid syndrome. Initial treatment we have given is octreotide and lanreotide. If they are well controlled, then surveillance with echocardiogram and pelvic abdominal CT every 12 weeks to 12 months. Okay. But if they are poorly controlled, octreotide and lanreotide is not able to control the symptoms of carcinoid syndrome. As we have seen, that it is only able to control diarrhea in 40 to 80% and biochemical marker in 40 to 70%. Then we have to find out the causes of uh, where the tumor is additional therapy for disease control. Like if a tumor is limited to the liver, then hepatic arterial embolization or cytoreductive surgery like hepatectomy reduce the tumor burden, and to consider telotristat for diarrhea and other systemic therapy based on the disease site. So main thing is, if the symptoms are not controlled, try reducing the burden of disease. So, and follow up surveillance to be done further. So which is not a symptom, side effect of octreotide: diarrhea, cholelithiasis, hyperglycemia, hyperkalemia. This is one. Please, what cannot be the side effect of octreotide? Yeah, the majority have answered A as the option. One person has answered D. The answer is hyperkalemia in this case, because hyperkalemia is not known to occur with octreotide. Hyperglycemia can occur due to increased hyper or hypoglycemia. Both can occur due to increased or decreased release of insulin or glucagon. Because if there is decreased release of glucagon, then it will cause hyperglycemia. I'm sorry, decreased release of insulin, it causes hyperglycemia. Decreased release of glucagon, it causes hypoglycemia. Cholelithiasis can occur due to cholestasis, and diarrhea sometimes occur as a side effect of octreotide because of the exocrine insufficiency of the pancreas. Okay. So there is steatorrhea and diarrhea occurs. So answer in this case is hyperkalemia. So metastatic disease. In metastatic disease, somatostatic analog are first line of therapy. They inhibit the tumor growth. In a trial octreotide given 330 milligram, it was associated with significant improvement in median time to progression. Other agents that can be used are interferon alpha. It stimulates T cell, inhibits angiogenesis, induction of cell cycle arrest in G1 G0 phase, and improvement of symptoms or if associated with carcinoid. Improvement of symptoms of tumor in about 50%. Interferon plus octreotide, it is not significant, not associated with any significant improvement in survival. Okay, so addition of octreotide to interferon is not improving any significant any survival rates. And side effect of interferon are flu-like symptoms, fatigue, depression, thyroid dysfunction, mild hepatotoxicity, and cytopenia. Other agents used are mTOR inhibitor, everolimus. In a radiant trial, they have found that improved progression-free survival from 4.6 months to 11 months. Everolimus in combination with octreotide has been associated with slight progression-free survival, but it is not significant. And side effect of mTOR inhibitors are aphthous ulceration, rash, hyperglycemia, cytopenia, pneumonitis can occur. Angiogenesis inhibitor like bevacizumab, sunitinib, pazopanib, they are all associated with significant clinical activity and improved progression-free survival. Cytotoxic chemotherapy has no activity in small bowel carcinoid. Carcinoid usually referred to a well-differentiated tumor. Etoposide and platinum regimen in high-grade neuroendocrine tumors like in small bowel tumor similar to lung small cell carcinomas. Another treatment modality is peptide receptor radionuclide therapy, PRRT. In this, lutetium 177 dotatate is used as a radio-labeled somatostatin analog, and 200 millicurie is infused over 30 to 40 minutes every 8 weeks for a 4 weeks treatment regimen. Eligibility criteria, they should be well differentiated neuroendocrine tumor and they should be SSR positive, that is somatostatin receptor positive neuroendocrine tumor that are detected with octreoscan or dotatate scan. Outcome, they have been found to be significantly improvement in PFS and objective tumor response, and in small studies they have found improvement in overall survival and progression-free survival also. Side effect of PRRT are myelosuppression because high dose of radiation is given. So myelosuppression, secondary myelodysplastic syndrome and leukemia may develop. Renal toxicity, hepatotoxicity, embryo-fetal toxicity can occur. Infertility, and patient can develop neuroendocrine hormonal crisis or carcinoid crisis at that time. And nausea and vomiting are also common, but they are more related to the amino acid infusion, which is required as a part of therapy for nephroprotection. So if patient has only liver metastasis disease, which is the most common site of carcinoid metastasis, distant metastasis, and hepatic cytoreduction. It is associated with improved symptom control in 70 to 100% and survival rates in 41 to 100% of patients. What are the techniques for cytoreduction? Are liver resection and other liver directed therapy like radiofrequency ablation, cryoablation, microwave therapy, and hepatic artery embolization. Liver transplant for liver metastasis is controversial and its indications are poorly defined. In 5 year survival rate is about 47% and disease free survival because most of the times the disease recurs in the new liver. Disease free survival is only 24%. And high burden of hepatic tumor, pancreatic primary, non-intestinal, and elevated Ki-67 index are negative index factors for liver transplantation. So liver resection is done in limited liver disease in which 90%, more than 90% of the disease that can be resected, preserving good future liver remnant and excellent palliation. It's an method for palliation of carcinoid symptom which occur due to hepatic mets and prolonged survival of patient undergoing complete tumor resection. Other factor can be other modalities that can be used for hepatic cytoreduction are radiofrequency ablation. They are usually used for tumors that are not near the major blood vessels and ducts and are less than 3 centimeter size. Microwave ablation, it is more rapid than radiofrequency ablation, that it can be used for tumor location near the blood vessels and it is associated with 90% control rate. Another is transarterial embolization, chemoembolization, or radioembolization. Basis for this embolization is that hepatic artery, it supplies the liver tumors as compared as to the normal, in comparison to the normal liver, which is mainly supplied by the portal vein. Tumors are metastases are mainly supplied by the hepatic artery, and response to transarterial embolization, major biochemical response is seen between 40 to 100%, symptom response between 67 to 100%, and radiographic response in between 33 to 66% of the patients. Radioembolization with yttrium 90 resin microsphere or glass microsphere is becoming now the procedure of choice for metastatic NETs to the liver. So metastatic disease, we have evaluated with CT, MRI, and somatostatin receptor based investigations. If complete resection is possible, then go for complete resection. And if it is asymptomatic, low tumor burden, then you can observe or give somatostatin analogs. If it is a local symptomatic primary, from primary tumor local symptoms are there, then resect the primary tumor and then consider for octreotide or observation. And if it is a clinically significant tumor burden, then octreotide, lanreotide, or other alternative frontline therapies can be given. So in case there is a disease progression after previous therapy, then further line of treatment is mTOR inhibitor everolimus given at 10 milligram per day, PRRT, peptide receptor radionuclide therapy with 177 lutetium dotatate. It is category 1. And liver directed therapy for liver predominant disease, and palliative RT for symptomatic bony mets, and cytotoxic chemotherapy if there is no other feasible options are there, and it is given for high grade neuroendocrine tumor. So a patient presents with neuroendocrine carcinoma with innumerable mets to the liver and lymph nodes. The tumor is poorly differentiated with Ki-67 index of 70% and mitotic rate of 20 mitosis per high power field, which is the treatment option. We should give somatostatin analog or go with sunitinib, cisplatin etoposide, or consider a mTOR inhibitor, everolimus. So answer given are C, C, D, D. Anybody else wants to try? So answer in this case is cisplatin and etoposide. As I've mentioned earlier, it's a neuroendocrine carcinoma. Neuroendocrine carcinoma are very high grade, even in lung also and otherwise also. They're high grade cancer. And in this question only, they are telling that Ki67 is more than 70%. So it is a very fast growing tumor, and mitotic rate is also 20 mitosis per 10 high power field. So it is unlikely to respond to our octreotide somatostatin receptor therapy because it is more commonly used for our well differentiated tumors, which are somatostatin receptor positive. So in this case, based on the similar line to lung cancer, cisplatin and etoposide is the treatment of choice. So grade 3 neuroendocrine tumors treated similar to small cell and large cell cancer of the lung. Metastatectomy is also not recommended in neuroendocrine cancers. And locoregional unresectable disease are treated with systemic chemotherapy and radiation therapy, as in small cell lung cancer of lung. And metastatic tumors, they are treated with systemic chemotherapy, that is platinum based with etoposide, irinotecan etoposide, and other combinations. Okay, so coming on to small bowel lymphomas, it is the third most common histological type of small bowel lymphoma. We'll discuss the lymphoma in brief. B cell type is more common than T cell. Median age is again around 60-65 years. Risk factors are certain diseases like inflammatory bowel disease, Crohn disease, ulcerative colitis, celiac sprue, immunodeficiency, congenital or acquired. EBV is Epstein-Barr virus, and H. pylori, Campylobacter jejuni infection. They usually have non-specific symptoms of lymphoma like fever, anorexia, nausea, vomiting, abdominal pain, weight loss, hematemesis, and melena. Abdominal mass or perforation is more common with Burkitt lymphoma and T-cell lymphoma. Abdominal pain, chronic diarrhea due to steatorrhea, protein losing enteropathy, and weight loss, they are more commonly associated with the IPSIT. What is the criteria for diagnosis of small bowel lymphoma? It is basically Dawson's criteria is used. In this, 5 criteria are absence of any peripheral lymphadenopathy, and there is no evidence of enlarged mediastinal lymph nodes. Number of total and differential white blood cell counts is normal total and differential WBC count. Predominance of bowel lesions at laparotomy, and the only obviously affected lymph nodes are in the immediate vicinity, and there are no lymphomatous involvement of the liver or spleen. So there are no other lymph nodes anywhere else in the body. Lymph node if present, there can be only near the vicinity of the primary tumor, no mediastinal, no peripheral lymph nodes, and WBC counts are normal, and no lymphomatous involvement of the liver and spleen. If there is involvement of liver spleen, it should be by the direct spread of the tumor. Like tumor has involved as a T4 tumor, involve the liver or spleen. Staging used for lymphoma are similar to other lymphomas. N Arbor staging. Stage 1 is limited to the single site. Stage 2 is confined to below the diaphragm, and 1E is with the regional lymph node, and 2E with distant lymph nodes. Stage 3 has involvement of organs on both sides of the diaphragm, and stage 4 widespread dissemination including liver and spleen. The most important prognostic factor in lymphoma is tumor spread. Most important GI lymphomas are of non-Hodgkin type, and treatment depends on the tumor type. Chemotherapy and radiation therapy are usually recommended as the first line treatment, but surgical intervention can be some lymphomas it is used as first line, or mainly it is reserved for complications such as obstruction, bleeding, and perforation. So these are the various lymphomata variants in small bowel. Most common is marginal zone B cell lymphoma, also called maltomas. It is the most common variant of small bowel lymphoma, associated with chronic inflammatory bowel and autoimmune diseases of the intestine. More common in stomach than small bowel, and predominantly occurs in men and in the sixth decade, associated with H. pylori and Campylobacter maltoma. Surgery and or chemotherapy can be given. Surgery is usually limited only for the if we develop symptoms, and H. pylori eradication therapy is used for treatment. Diffuse large B cell lymphoma, more common in the ileocecal junction in men in fifth decade, and it is associated with immunosuppression. And surgery followed by adjuvant chemotherapy is recommended for large B cell lymphoma because it is involving the ileocecal junction, most commonly present with intestinal obstruction, and because of those symptoms. So surgery is preferred. And 5-year survival is about 50 to 70% with multimodality therapy. Burkitt lymphoma, they are associated with EBV and more commonly present in the endemic areas of Central Africa. It accounts for less than 5% of small bowel lymphoma. And GI is involved in about 20 to 30 cases of Burkitt's lymphoma. It is also common in ileocecal region. And as it is a very high mitotic index and very fast growing tumor, and chemotherapy is the mainstay of treatment in this thing, and it is associated with c-myc gene translocation between T814 or T28 genes chromosomes. Mantle cell lymphoma usually occur in men in fifth to sixth decade, and they are 70% associated with stage 4 disease. Okay. Chemotherapy is mainstay of treatment in this case also. And T cell lymphoma, they are enteropathy associated T cell lymphomas. They are usually associated with celiac disease, and in those cases 25 to 100-fold increased risk of developing enteropathy associated T cell lymphoma, and more common in jejunum and proximal ileum. They account for less than 15% of small bowel lymphomas. In this case also, chemotherapy is usually indicated, but surgery in case there is symptoms. So question about lymphomas is, which of the following are characteristics of malt lymphoma? You can answer two correct options are. What is the characteristic of mild lymphoma? Association with Hashimoto thyroiditis, majority present with stage 1 and 2 disease, more common in women, associated with translocation. We are asking what are the options, characteristic they are associated with this thing, and not associated. So some people have answered C, D, and D as the option. A. Okay. So usually they are present with Hashimoto's. They, as we have discussed in this chart, they are usually present with autoimmune diseases. Okay, and mainly present in the men, and also they, another thing which I have not shown is that they usually present with stage 1 and 2. So answer A is correct, and answer B is also correct. They are usually presenting in early stages as compared to Burkitt lymphoma or mantle cell lymphoma. They present in early stage and more common in men, and they are not associated with the translocation. Translocation is more commonly present in Burkitt's lymphoma. T1114 translocation is more commonly present in the mantle cell lymphoma. But in Burkitt, translocation 814, 28, or 822. Okay. So answer to the question is A and B. Lastly, we'll be coming on to the appendicular neoplasm. This is the last topic for today's class. So appendicular neoplasms, they can be classified into epithelial neoplasms or neuroendocrine neoplasms. Epithelial neoplasm can be invasive adenocarcinomas or low-grade appendiceal mucinous neoplasias and high-grade appendiceal mucinous neoplasias and goblet cell adenocarcinomas. Goblet cell adenocarcinomas, also called as goblet cell carcinoids or adenocarcinoids, they have some component of neuroendocrine cells in this, but majority is adenocarcinomas, so they are grouped under the epithelial neoplasm. Neuroendocrine neoplasms, they include well differentiated neuroendocrine tumor, poorly differentiated neuroendocrine tumors, and mixed non-neuroendocrine and neuroendocrine neoplasms, meaning for mucinous neoplasm of the appendix, they classified into non-neoplastics are mucocele. Neoplastic mucinous neoplasms are serrated polyps, low-grade appendiceal mucinous neoplasm, high-grade appendiceal mucinous neoplasm, and invasive adenocarcinoma, as we studied in epithelial tumors also. Another thing for in appendiceal carcinoma is development of pseudomyxoma peritonei. It's a clinical syndrome. It is differentiated, characterized by diffuse mucinous peritoneal involvement, often in association with the mucinous appendiceal lesion. Okay, so there are a large amount of mucin which is present in the peritoneal cavity. So the pathology is like if there develops a cyst adenoma or low grade and appendiceal mucinous neoplasm, it occludes the lumen of the appendix, and mucin accumulates into the appendiceal lumen and forms a mucocele initially, and then it ruptures. After rupturing, the peritoneum is seeded with the mucus containing cells, mucus producing cells, and filling the peritoneal cavity with the mucinous fluid, also known as jelly belly. To categorize pseudomyxoma peritonei, Peritoneal Surface Oncology Group International has proposed a classification in which they are classified into two groups, that is low grade or acellular pseudomyxoma peritoniae. Low grade correspond to the ruptured low grade appendiceal mucinous neoplasm LAMN, and appendiceal mucin PMP refers to mucocele. They are non-neoplastic. And second grade is high grade or signet ring cell pseudomyxoma peritoniae, which correspond to peritoneal mucinous carcinomatosis. Another terminology used commonly with uh, mucinous neoplasm is disseminated peritoneal adenomycinosis, DPAM. It is the spread of intraperitoneal mucin from a ruptured low-grade mucinous neoplasm or from benign mucoses. It is in the same as the first classification, low-grade or acellular PMP. So defined as abundant peritoneal extracellular mucin containing scant mucinous epithelium with little cytological atypia. They are usually well differentiated or mitotic activity and with or without an associated appendiceal mucinous neoplasm. So there is abundant mucin, some cells, and they are also well differentiated. So based the survival based on various histological classification, DPAM, peritoneal adenomycinosis, it's even after 5 year median survival was not reached. It is about 80%. Median survival is about 80. They are very slow growing and very indolent growth. Whereas peritoneal mucinous carcinoma and peritoneal adenocarcinoma, they have very uh, poor prognosis compared to the low grade tumors. Coming on to epidemiology of appendiceal neoplasm, about 0.5 to 1% of the intestinal neoplasm are formed by appendix cancers, and most mucinous appendiceal neoplasms, they are diagnosed incidentally at the time of appendicectomy. Patient underwent appendicectomy and found to have a mucinous neoplasm. Appendicectomy can be for lesion for symptoms of appendicitis. So malignancy is found in approximately 1% of the appendicectomy specimens. Neuroendocrine tumors, about 11 to 18% of the appendiceal neoplasm. Some old series have said that neuroendocrine was most common of the appendiceal neoplasm, but and they said about 50% of appendiceal neoplasm are neuroendocrine tumor, but recent series have shown that only 11 to 18% are neuroendocrine. And most common histology is adenocarcinoma, followed by intestinal type adenoma. Most common is mucinous adenocarcinoma, followed by intestinal type adenocarcinoma. And third most common is neuroendocrine tumors. And presentation most commonly is by in the form of acute appendicitis. Some present with ascites, abdominal mass, or generalized abdominal pain, and it is found incidentally in about 20% of the cases. Histological types, as I told, most common adenocarcinoma is mucinous, can be differentiated into well, moderately, or poorly differentiated, and well differentiated types are associated with pseudomyxoma peritoniae. Second common is intestinal or colonic type of histology in adenocarcinoma. They more commonly form focal mass without mucocele formation. So there is not a production of mucus is not produced in this thing, and they usually form a mass. And so if mucus is not produced, there is no rupture of mucin and formation of pseudomyxoma. They have high incidence of nodal metastasis. They are in line with the colonic tumors. Another is signet ring cell tumor. They correspond to the poorly differentiated version of mucinous carcinoma. They are the least common with the poorest prognosis. Staging workup, CT chest abdomen, colonoscopy to be done, because 30 to 40% will have concurrent colonic neoplasia also. Biopsy, if possible, and tumor markers like CA, CA99, CA125 to be done. As most commonly, it is presented as a symptom during appendicectomy, or so biopsy is only available after the specimen has been removed. So staging for appendiceal carcinoma is carcinoma in situ. TIS is intramucosal carcinoma with invasion of lamina propria, but not through the muscularis mucosae. For LMN, there is another category created for low-grade mucinous neoplasm, and they are considered to be carcinoma in situ, but they invade into the muscularis propria. Okay, so they are not limited to the muscularis lamina propria or muscularis mucosa. They invade till the muscularis propria and still considered carcinoma in situ. So T1, T2 is not applicable to LAMN. Okay. For intestinal or other mucinous adenocarcinoma, T1 is when tumor invades into the submucosa, T2 when it invades into the muscularis propria, and T3 invades into the muscularis through the muscularis propria into the subserosa or mesoappendix, and T4 if it invades the visceral peritoneum, including the acellular mucin and mucinous epithelium also invade the visceral peritoneum, it is T4A, and T4B if it is adherent to the adjacent structures. Nodal masses, N1A is 1 lymph node positive, N1B 2 or 3 lymph node positive, N1C without lymph node but there are tumor deposits in the mesentery, N2 is 4 or more lymph nodes are present. Okay. M1 staging, M1A is also different, like intraperitoneal acellular mucin without cells identifiable is M1A. M1B is intraperitoneal metastasis only, and there are peritoneal mucinous deposits containing the tumor cell. If there is mucin deposit without tumor cells, it is M1A, and if there are tumor cells identified, it becomes M1B, and M1C is metastasis to other sites other than peritoneum. Okay. So this is again the T staging. T1 is submucosa muscularis propria beyond muscularis propria but not invading the serosa or into the mesoappendix. T4A is into the it invades into the serosa and spillage of the cells into the peritoneal cavity. T4B is if it involves the other structure like small bowel, most commonly involved, or it can involve other structures also. So similarly, the prognostic groups are nodal positive are graded into stage 3 and metastasis stage 4. In this, another important thing is that grading is introduced for M staging. For stage 4A is M1A when no cell is identified or when cells are identified along with the mucin but they are of grade 1. Okay, so it is stage 4A. In stage 4B, if cells M1B with grade 2 or grade 3 features, and stage 4C is beyond the peritoneum, M1C. Local staging, local treatment for stage 1 to 3 if it is diagnosed at the time of surgery. Suppose we have opened and have found that at the appendix we have found a tumor is there, mucocele or tumor. So there are different opinions about appendicectomy and right hemicolectomy between various groups, but American Society of Colorectal Surgeons, they have recommended right hemicolectomy rather than simple appendectomy alone, and others have advocated simple appendectomy for all unruptured, completely resected mucinous tumors that are well differentiated. So this is difficult to know at that time, differentiation. So right hemicolectomy to be done at the time of surgery if it is diagnosed. For those who are incidentally diagnosed tumor, those patients which have completely resected, unruptured, well differentiated mucinous adenocarcinoma diagnosed after appendicectomy, whether to go for right hemicolectomy again or observation. One group suggests right hemicolectomy because it offers lymphadenectomy, and other groups suggest only observation. SEER database have shown no difference in survival, and acceptable approach for local treatment is post appendicectomy if it is localized, well differentiated, and with negative resection margin invading no deeper than submucosa. So it is T1 lesion is to do nothing further. So T1 lesion localized, well differentiated, negative margin, um, to do with appendicectomy only and not right hemicolectomy. For ruptured tumors, appendicectomy, again the confusion with versus appendicectomy or right hemicolectomy. In this case, right hemicolectomy is preferred if the rupture is contained by the right colon and mesentery. And then we do peritoneal washings, careful inspection of the abdominal cavity, and biopsy of any suspicious peritoneal lesions. Routine oophorectomy is only to be done in patient with ovarian metastasis, and no role of oophorectomy, prophylactic oophorectomy. Adjuvant chemotherapy, its role is not well established. Extrapolation of data from colon cancer, it's associated with adjuvant 3 to 6 months of oxaliplatin based chemotherapy for node positive adenocarcinoma to be given. And according to National Cancer Database, it has been found that stage 2 and 3 tumors, they are associated with significant survival benefit with the use of adjuvant chemotherapy, Folfox based. And metastatic adenocarcinoma, again, no studies are present. So based on colorectal cancer, Folfox, Capox, or Folferi can be used, or single agent, those who are not able to tolerate uh, combined therapy. And bevacizumab is shown to improve median progression-free and overall survival in some, but cetuximab and panitumumab has no established role in this, in appendiceal carcinoma. Role of cytoreductive surgery and HIPEC in appendiceal carcinoma, there is again limited data, and for appendiceal carcinoma, its benefit is less than if done for mucocele or low-grade appendiceal mucinous neoplasm. So best suited patients who are best suited for this approach are those with the good performance status, limited disease, limited or no or limited extraperitoneal disease after an initial period of systemic chemotherapy. So in patient with extraperitoneal disease also, if after giving chemotherapy it is limited and easily resectable, then they are also candidate for HIPEC. And small volume peritoneal disease, that is more likely to be successfully cytoreduced. As we known in the last class, if we are leaving deposits less than 2.5 mm, that is CC score 0 or 1, then it is more likely to be beneficial than leaving more than 2.5 mm nodes deposits behind. And histology, signet ring cell carcinoma is having the least favorable outcome, but it is again not a contraindication for CRS and hyper. Only one randomized control trial, Dutch trial, has shown that median survival is significantly lower in patients with HIPEC, that is 22 months compared to 12 months, those who do not undergo cytoreductive surgery. And various small institutional and prospective data has also shown some benefit of HIPEC in peritoneal carcinomatosis. The role of neoadjuvant before surgery is limited and not much trial. Another variant of adenocarcinoma is goblet cell adenocarcinoma, and they are called goblet cell carcinoid or adenocarcinoid. Age of presentation is around 50 to 58 years. The more common, closer to the adenocarcinoma than neuroendocrine. And symptoms usually present with appendicitis, abdominal pain, abdominal distension, bowel obstruction, and other unspecified symptom. And 40% present with distant metastasis to peritoneum, liver, and ovaries, like Krokenberg tumors. And histological hallmark is presence of goblet cell shaped epithelial cells with mucin, and which may cluster in the lamina propria or submucosa of the appendix, leaving the mucosa intact. It has been classified, goblet cell adenocarcinomas have been classified into three classes based on Tang classification. Typical goblet cell adenocarcinoma is Tang A. They are registered in 48% of the total cases, and 5-year survival is about 100%. And another variant is adenocarcinoma, X goblet cell carcinoid. There are two types, signet ring variant, Tang B has 5-year survival of 38%, and poorly differentiated adenocarcinoma type C has 5-year survival 0%. So they are positive for PAS, IHC, they positive for chromogranin A, synaptophysin, CA, and CK20. And tumor marker, there is no role of chromogranin A. In the previously, IHC chromogranin A can be positive, but blood tumor marker of chromogranin A is not useful for appendiceal GCA, goblet cell adenocarcinoma, because they are majority are adenocarcinoma component and only small component is neuroendocrine. Other markers are CA, CA125 and CA99 are better for GCAs because they are elevated in about 80 to 80% of the patients. Staging is similar to adenocarcinoma, and prognosis is good for stage 1 and 2, and intermediate around stage 3 is 57%, only 19% for stage 4, but its prognosis is better than the malignant, uh, better than the appendicular adenocarcinoma, and worse than pure neuroendocrine tumors. So for localized disease, right hemicolectomy is preferred according to the American and European neuroendocrine tumor classification guidelines. Appendicectomy has also been shown to be effective in localized disease by some studies. So preferred is right hemicolectomy. Role of adjuvant chemotherapy is unknown, but some gives on the similar lines to adenocarcinoma like CAPOX and FOLFOX. And recurrent metastatic carcinoma, its treatment depend on the predominant histological component, whether it is uh, adenocarcinoma or neuroendocrine. Okay. So peritoneal deposits from adenocarcinoma component, if there are peritoneal deposits, then there comes the role of cytoreductive surgery with HIPEC, and better results are for well differentiated Tang A than for Tang B and C classification. So according to AJCC staging criteria for adenocarcinoma of the appendix, at what point the tumor grade is utilized in order to assign a combined tumor stage. So we have used a grading system also in the appendiceal carcinoma In what you use, in T staging, N staging, or M staging? So options are: when a tumor extends to the surgical resection margin, when a tumor has cellular intraperitoneal metastasis, when a tumor involves the muscularis propria, or when a tumor is a goblet cell carcinoid. Hmm. The answer is B. When tumor has cellular intraperitoneal metastasis, that is M1B. M1A is acellular intraperitoneal mucin deposit, and M1B is cellular. So for well differentiated, it comes into M1A, and poorly differentiated grade 2, grade 3 comes into M1B. Coming on to pseudomyxoma peritonei, it is peritoneal dissemination from ruptured LAMN or benign mucocele, also termed as diffuse peritoneal adenomycinosis, more common in female. Most common symptom is increasing abdominal girth. Second most common symptom in men is inguinal hernia, and women it is ovarian mass, which is palpable at the time of pelvic examination. And radiologically, you'll see scalloping of the liver, spleen, and mesentery. And there can be calcification can also be seen, and undersurface of the diaphragm is greatly thickened by the large cystic masses of tumor, and characteristic is this peripheral location of the tumor and relative sparing of the central, uh, with central displacement of the small bowel and mesentery. This is called a redistribution phenomena. And management, treatment can be initial expectant management can be, that is observation for asymptomatic patient with limited peritoneal disease, with no or limited disease on imaging, and low grade mucinous neoplasms who underwent resection of the primary tumor. So if there is very small tumor deposit and that too is very low grade, and that can be followed up, observed. Other patient can undergo periodic surgical debulking, though patient who develop uh, symptoms due to abdominal distension and intestinal obstruction like symptom because of the mucin, they can go undergo surgical debulking. And the preferred choice is aggressive cytoreduction with HIPEC. And it is outcomes are usually based on the histology, as we are known that tang A is better than tang B and C. And PCI index is how much tumor is present at the time of uh, when we open the abdomen for. And then lastly is CC score. CC score is completion of cytoreduction score. It is in the end of the surgery how much tumor is left. No visible tumor, less than 2.5 mm, or more than 2.5 mm tumor deposit. Based on these three indices, outcome is decided. So another question is: a 30-year-old gentleman present to emergency with symptoms of right lower quadrant abdominal pain, nausea, vomiting. Physical examination shows BP is 120/70, pulse is raised, abdomen is soft but tenderness in the right lower quadrant with positive rebound. WBC count is raised, and CT shows acute appendicitis. So he presents with acute appendicitis and underwent appendicectomy. And pathology confirms acute appendicitis, and there is additional 2.1 into 1.5 centimeter tumor. and it is neuroendocrine tumor. CK20 positive. So what is the answer? B. Long-acting release octreotide. So it is a case of neuroendocrine tumor. It's not a mucinous adenocarcinoma. It is not also not LAMN or mucinous neoplasm. It's neuroendocrine, purely neuroendocrine, not a goblet cell adenocarcinoma also. Their positive marker for neuroendocrine are positive. Ki67 is 3%. It is well differentiated tumor. Okay. And size is 2.1 into 1.5. It is T2. Okay. So in neuroendocrine tumors, if size is more than 2 centimeter, then our next step of choice is re-exploration and right hemicolectomy. I'll just explain you in according to NCCN guidelines also. T1 tumor which are confined to the appendix, it is simple appendectomy to be done. Okay. For T2, T2 to T4 tumors, okay, those with incomplete resection, positive margins. So only feature in this was T2 tumor. I'll just explain the neuroendocrine staging for appendix also. Next slide. For T2 tumor, recommendation after initial staging evaluation, re-exploration and consider right hemicolectomy. In neuroendocrine tumor, tumor less than 2 centimeter is T1, more than 2 centimeter, less than 4 centimeter is T2, more than 4 centimeter with subserosal is T3 and other. Okay. So for T1 only, we can ask for simple appendectomy and follow up that patient. And for T2 and above, right hemicolectomy to be done. This was in contrast to the mucinous appendiceal carcinoma if found on the appendicectomy specimen. So NCCN also recommends aggressive therapy for 1 to 2 centimeter tumor with poorly prognostic features such as lymphovascular or mesoappendiceal invasion or atypical histological features. So even if the tumor is less than 2 centimeter, if it has poor prognostic features such as LVI and mesoappendiceal invasion or atypical histological features, then to be considered for aggressive treatment in the form of right hemicolectomy. Okay, so that brings to the end of our class. Thank you very much. If you have any question, you can ask me. These marker question we'll discuss again. I'll clarify every details in the WhatsApp group. Okay. Stop sharing now.
Yeah. Yeah.
Hello.
Thank you, sir. We had a great session with you. And if anyone has any questions, you can ask them right now, or else you can end it now. Okay. Seems like nobody has any questions. So, we had a great session.
Thank you very much. Thank you, everyone.